The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module. Designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invos 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invos 7100 system provides innovative, next-generation improvements over the Invos 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module, designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invos 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invos 7100 system provides innovative, next-generation improvements over the Invos 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module, designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invos 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invos 7100 system provides innovative, next-generation improvements over the Invos 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the Lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module, designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invos 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invos 7100 system provides innovative, next-generation improvements over the Invos 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when...
Welcome back. We have another outstanding group of speakers today you won't want to miss. European COVID experience, ABCP update, keynote speaker, and one of my favorites, the Ken Farmer Memorial Scholarship for our students. We've had approximately 600 registrants, not counting exhibitors. We've had presenters from all over 5 countries representing Germany, Netherlands, Turkey, Belgium, and the US. Also, a huge shout out to all of our coworkers out there who are covering for us to be able to attend this meeting. Thanks to our vendors that have helped sponsor this meeting and the speakers. We really enjoyed Shark Tank last night. It was very entertaining. Don't forget to complete your evaluation form located at the PDC login page and let us know how to improve this for next year. Hopefully we will be in person next year because I am looking forward to seeing all of you on the beach in Sanibel. Today, our moderators and panelists is Susan Englert, wave Susan, Bill Harris, Ty Walker, and Brian Lynch. And a huge shout out to Terry King, who has been behind the scenes doing all of our IT for us all this week. So yes, thank you, Terry. So our first speaker today is Luc Huis. He is a perfusionist from Belgium. He was a liaison to the ICBP and co-chair for the 2019 EATS guidelines on cardiopulmonary perfusion. He is also the author of the Tiny Perfusion Letter for all of you that subscribe. So today he is going to be speaking on the European ECMO experience with COVID-19. Thank you, Luc.
Thank you for the nice introduction. Let me share my screen. That looks all right. So thank you, Carla, for the nice introduction, and thank you for giving me the opportunity to talk to you about this European ECMO experience with the patients on COVID. And I don't want to say I'm the expert in ECMO, and certainly not in Europe, but I'm just taking a look at the numbers and keeping an eye on what is happening around here. And so I want to report on that and give you my personal opinions as well. So, yeah, I have no conflict of interest to declare regarding this presentation. And the outline of my presentation will be in 3 parts. I will talk a little bit about what's happening in the literature very shortly, because there's tons. Discuss some of the registries that are there. Then I will go deeply into the situation that we experienced in Belgium, and then take it, expand it to Europe, and then compare it to the USA and the rest of the world with the ELSO registry. And then I'm going to just briefly touch on some observations that I made during what I saw clinically and what I saw in the literature regarding some of these subjects that happened. So if you want to know how do I treat my patient on ECMO, then with COVID-19, then good luck, because there's a massive explosion of literature on COVID-19 alone. This is from April 11. Sorry, the date is in European. From April 11, and in 2020, this bar there was more than 190,000 publications, and in 2021 we already are at more than 40,000 publications. And that means that around every 3 minutes, there's a publication about COVID-19 somewhere. So it's really hard to find and to dig in the literature, but there are some publications that are worthwhile, and I will share you some of those later. So in the beginning of the pandemic, and that was even before Sanibel 2020, there were reports, the first reports of people that were put on ECMO in China were really bad, and they were there was a high mortality, and that was probably because there was not enough knowledge around the disease and the treatment of these patients. And this led to many people saying that that ECMO for COVID would be a futile therapy, and we should keep it for patients that were actually worth putting on ECMO. And many people advised against it, but of course there was not much alternative, in fact. And this is another publication from that time, March-April 2020, from Mexico, where they recommend to not put patients on COVID-19 because there's a high mortality. And so, despite all these negative reports in the beginning, there was no alternative, and people were actually suffering to get cured, and with low PO2s and low saturations, and so we prepared anyway for COVID ECMO wave, and we started looking for materials and hardware and software and disposables. Sorry, and this led really to preparing ourselves for an ECMO wave, and the waves have come. That we've all seen that, and this has led then later to the first recommendations from the ELSO. Not really based on much knowledge or evidence, but nonetheless they try to guide perfusionists and ECMO and carers for ECMO patients all over the world with some recommendations that were really useful and could help us in providing care to the patients. Now there's a lot of talk about the pathophysiology of COVID. There is what we can say is that the disease is very complex and plays on many levels of the body systems. Not only infectious, but the infection leads to a high inflammatory response, and the inflammatory response leads to a lot of coagulation disorders and endothelial problems, and it's not easy to know which patient is going to react in a certain way. The disease is very unpredictable and can be really problematic in some cases. But obviously, I don't have to tell you all that because you know that. But if I would recommend something that is very useful to read on ECMO or COVID-19 and the pathophysiology and how it affects the coagulation system, I would recommend this article by Dr. Magnani. And it's a really extensive description of what happens when patients get COVID-19 and how it works on the different levels of the different systems in your body, and with a special emphasis on coagulation. And he uses this scheme or this figure to try and describe how just the COVID-19 infection works on the different systems and how it affects all of these body functions and coagulation systems. And you might see that there's a lot of these syndromes or factors that we see here are very common for us, because there's another thing that also plays a role in all these things, and that's cardiopulmonary bypass or extracorporeal circulation, for that matter. And we see a lot of we see a lot of problems sometimes with endothelial damage. We know that there's endothelitis sometimes with cardiopulmonary bypass, stasis of blood. The platelets and the monocytes get activated. We sometimes see HIT patients. So there's a lot of interplay, not only from the the point of view from COVID, but also if we interfere with our systems, then we play a role in that as well. And it's not always easy to know in which stadium the patient actually is in the disease. So which thing should we treat first, or what can we rule out to make the patient better? So it's a very complicated thing. And this slide was from another presentation of me. So we're not the only culprits. It's also when you saw a patient in half, when you open his sternum, you activate him, of course, you get a reaction. And the only discipline, ICU and anesthesia, are actually the only caretakers that actually do something better for the patient. And as an anesthesiologist always told me, anesthesia is good for the patient, and I think she was really right this time. But anyway, this is just to show how complex it is and how difficult it is to gain knowledge, because there's a lot of things coming out. And then there's also registries and surveys that we see appearing. Of course, there's the ELSO registry and the Euro ELSO registry, which were already existing, but they really did a great effort to pick out the COVID-19 patients and to gain information, to share also the knowledge. And I think from there's been a few recent publications that are really detailed in what's happening with these patients and the blood values. And I think from now on, we will see a lot of reports from these registries. I will touch briefly on the genomic trial, the ECMO card study, and the Generate project, because I know that a lot of way smarter people than me have talked about this and described this. So I'm going to touch them briefly. So the ELSO registry, so it's called the full COVID-19 registry, and you can all find this data on their website. I'm sure somebody has talked about this, but we see that there's a whole lot of patients that have been put on ECMO all over the world, and the greatest number was in North America, but we see a lot of European centers contributing to ELSO as well, and we will see that this is only a small cohort of the Euro ELSO patients. And then I don't know if it is because there are less ECMOs or because they report less, but the contribution to the Euro ELSO registry, to the ELSO registry, excuse me, is a little bit less, but I don't know what causes this. Then the Euro ELSO registry is in fact the same as the ELSO registry, but what they did was as soon as COVID hit, they set up a survey especially for COVID-19 patients. And what they do is they have a weekly roundup. Every week they gather data from the centers that contribute, and they send out reports, which you probably will have seen on Facebook or LinkedIn or other or Twitter or something. And I've taken a look at the current situation on April 12th, so almost a week ago. And there's 191 centers from Europe, from 22 countries contributing. And at this moment, there's 3,900 cases that are being followed, of which 500, a little bit more than 500 are still ongoing. And of those patients that have stopped, like 3,900 minus the 917, excuse me. Of those, 1,800 were weaned, so 53% were weaned, and then almost 1,600 patients died on ECMO. So that's a high mortality for mostly VV ECMO. And then the Euro ELSO survey also reports 122 patients dying after weaning. So overall, the mortality, if you are put on ECMO for COVID-19, is exactly 50%. And we will see later if this correlates or is in accordance with the other registries. So that's a 50-50 chance of survival when they were being put on ECMO for COVID-19. They also report on the configurations that are used. So 9 out of 10 are VV ECMOs, and then the 5% are VA, and others can be VAV or VVA or ECO2 removal, ECHO patients. And then we see a mean age that is around 53, and 4 out of 5 patients are male that are being put on ECMO. That's some of the information that you gain from them that they send out every week. So this is, for example, from LinkedIn, but you can find it on their website as well. It's an overview of all the centers contributing with the numbers. For example, France has on April 12th, they had contributed 535 ECMOs from all these centers. And it gives you a little bit of an overview of what is happening in Europe. They also give a trend. They also give some trends. These are the actual total numbers of ECMOs that have been reported from, but this is only the second wave, September till now, till April, September 2020 till April. Yes, these are the participating centers, so it's still growing, which is a good sign. We have the ongoing ECMOs, the patients that have been weaned from ECMO, and the disease trend either on ECMO or in the little gray bars, the deceased after weaning. So you can really follow up what's happening in Europe with regards to the numbers of ECMO patients. And also every week they give the trends for the mean age and the percentage of male, female, and also the configuration. And I must say that trend has not really changed over the whole of the reporting cycles. So it's been pretty much younger patients, and 4 out of 5 are male patients. And most of them are treated with VV ECMO. Then very shortly, the ECMO card study is something that is happening. It's not really in Europe, but I just wanted to touch on that. And this is this study was started up to make sure that every COVID-19 patient and the treatment was recorded and reported, and I'm pretty sure that soon enough we will find some publications from them. And you've probably seen these nice infographics from I can't remember her name now. There she is, Miss Fella Antonini, and she really, is publishing this and keeping us up to date with what is happening everywhere. Then there is the Generate project. I think someone spoke about this, Justina Swol. I saw it passing in her presentation, and this is just trying to locate all the European ECMO centers and trying to analyze whenever there is another pandemic, if we have where the availability of the ECLS is, and where we can send patients, because I'm not showing it in this presentation, but it's from the literature. It's become clear that the more you centralize care, so the more centers have patients, the more patients they have per center, the better the care is and the better the survival. So that's something important, and I think the Generate project will contribute greatly to this. And then just for the information, the Genomic project is basically looking. It's been an ongoing study. It's a global effort to try and understand how people are being treated and how critical illness works, with an emphasis on genetics, because we see, for example, for COVID as well, that genetics play a very big part in how the body reacts to the disease and how the inflammatory response is aggravated or not. And so they already had a survey, a registry, so they work together now with the Asian Pacific ELSO community to reach out for those, to look at the patients that are on for COVID-19 that are put on ECMO, veno-venous ECMO. So also probably soon we will get some results from that as well. So what is the situation in Belgium? We're going to the part where we look at how the situation is in the different sides of the world. Belgium is a very small country, only 11.5 million people live there, but we have a lot of cardiac centers, too many, most people say, but it's a political issue. And we don't know really how many ECMO centers there are. There are 15 reporting to the Euro-ELSO survey, but there is no mandatory reporting for ECMO centers. And so some non-cardiac centers also perform ECMO, but it's hard to put a finger on it. So we have no statistics on the number of ECMOs yearly. I found some reimbursement website that talks about 515 ECMOs in 2019, so pre-COVID, and now we are probably way above that number. But what we do have, and that is a very nice tool, that is since March 2020, all the hospitals have to report daily to the government with regards to how many patients there with COVID there are in their hospital, how many are on respiratory support, how many are on ICU, and how many are on ECMO. So that's very convenient. And I've pulled out the numbers for you, and you can clearly see the 3 waves that we have experienced or are still experiencing. So this is the total of the hospitalized patients only in Belgium. And so we start in March here, and we have our first wave, which was like really shocking us, and this was the worst we've seen. And then by June, July, it calmed down, and we had a relative calm summer, but we still had restrictions, although we tried to reopen a lot of things. And then, although they had warned us that it would happen, we were still shocked that by October, the numbers were going up again, and we experienced a very hard second wave that lasted at least until January, but is still ongoing. In fact, it never calmed down. And now we are experiencing a third wave, which is really, it's getting hard to suppress that wave, to keep it down. Because obviously there are some variants. Our vaccination has gone a little bit on the slow path, but it's gaining speed now. And lastly, the people are really sick of being restricted, and there's a lot of I would say protest, but the people are getting tired of it. So that's also a huge problem to try and stick to the limitations. Then projected upon that, and please be aware that the dark number is the patients in ICU, but the scale is different for the dark scale. So, but it follows nicely. Number of people in ICU almost similar. We're trying to get them down, and they are slowly going down, the numbers on ICU, but it's a daily follow-up. And if we look at the number of patients that are being on respiratory support, then we had a higher peak at the first wave, and it was better. We had better knowledge of how to ventilate patients or how to avoid to ventilate patients, and I think that reflects here in the slighter lower number of patients being on ventilatory support. But if we look at here on the red line, the number of patients on ECMO, that is for every day. So the first wave, the highest number was around 48, I think, patients on ECMO on the same day. And the second wave, we put a lot of lot more patients on ECMO. Excuse me. So we were almost at I think the highest number was 93 or 96 patients on ECMO at the same time, and that is really something that we've never seen in Belgium before. Like probably like in most other countries or areas. And then we were actually going down, but we always follow the wave, and this time we even preceded the wave, so we have less people on ventilatory support. Well, not less people, but the number of people, the percentage of people that had to go on ventilator support was lower than the percentage of people that went on ECMO, because we see really the third wave in severity of disease is even harsher than the second wave. We really see very, very sick patients. They're also younger, so they react. They have a higher inflammatory response, so that's really, really bad numbers for the moment on ECMO. And they're really actually still. I was in the hospital yesterday, and there were still patients coming in and going out and getting off ECMO, and they're mostly very young. Probably because most of our older people are vaccinated or have died in the previous waves. So, and if we look at the European numbers, and these are the ongoing cases, so we have the same first wave, and then during the summer it was relatively calm, although the numbers were still high. And then in October, the second wave started, and it has never subsided. They speak now about the third wave, but the third wave is actually the same as the second wave. And I think you can see this is the reflection of the variants, the British, the South African, whatever country they originate from. This is what is reflected here, and also probably because because people are not paying attention anymore to restrictions. Okay. So I'm not going to go deeper in this. If we look at the different countries in Europe, then we see that, for example, France, Germany, and the UK, they have a high number of patients, but a low number of centers. And that means that the average number of cases per center is higher in these countries, and especially in the UK, where they have like, for the same population almost the same population as France or Germany, they have like way less centers, only 6 centers, and they really are centralized. And we see in the literature that is very important for the outcome of the patients. If we look at Spain, which has only like 1/3 or half of the Germany or France population, they have a way higher number of centers, just like Italy, Belgium as well, and we have a lower number of cases per center, which we should try to avoid. In fact, Russia is a little bit an exception. They have a lot of centers, but this is a huge country. You know, if you talk about the USA, they have 4 time zones. Russia is spread over 9 time zones, so they have a huge distribution of people, and they have some centers that have a lot of cases, like the maximum is 61, and then half of their centers, the median is 2, so half of their centers only have 2 or less patients treated. So there we see the difference in how the care for the patients is decentralized or not in different countries. So to conclude, for the situation in Europe, there's no centralized reporting. Also, the management is decentralized, like there's no EU management, or everyone has to take care of their own, is able to take care in the way that they want for ECMO patients or COVID patients, which is, in my eyes, a problem, I think. But there is a strong collaboration nonetheless. You can pick up the phone and call someone in a center that has a lot of experience and ask him, I have this patient, or I have I have this problem. What do you recommend? But there are no statistics on the actual number of ECMOs or the specifics. And I think that if you are a center that wants to do ECMO, then it should be mandatory to report your outcomes and your numbers. But that's a different discussion. And this is a great opportunity to prepare for the next pandemic, because it's not a question of when, it's not a question of if it's going to happen, but when. Now, I'm almost done. The situation in the rest of the world, I've showed you these numbers from the ELSO registry, and it's very hard to know these 1,474 patients from the Europe, if they are included in the Euro ELSO survey or not, or if they are only in the big ELSO. So there is a little bit of a miscommunication between the different continents. And once again, a lower number of patients from other countries. But if we look at the statistics, and I've taken this from the website, the spread in this is ELSO, so a bit of Euro ELSO and North America, and then the rest of the world. And this is Euro ELSO, so only the countries in Europe. And we see that there's a little bit more males in Europe being put on ECMO. The age is a little bit older, but not really. I don't think that this is statistically different. And the distribution, we have a little bit more respiratory ECMOs, and this is also a difference in just the terminology. We speak about VV, VA, or other, and in the US it's respiratory, cardiac, or ECPR. And also in America, they talk about the status post-ECMO, and we talk about weaned. But we can clearly say that the mortality is overall is the same between the different registries around the world. Then, as I told you, we have very sick patients, some of them with many comorbidities and a high mortality if we put them on ECMO. It seems like there is a higher need for anticoagulation, or we might need to switch to alternatives, or maybe suppress more the inflammation. There is a tendency to have a faster oxygenators change out or system change out, but it's not sure what markers we should use to make that decision. There is a switch to a more ICU management, certainly in Europe, and maybe that is what is causing this change. And well, the outcomes, is there still room for improvement, or is this the best that we could do? So maybe the genetic profiling can be an answer to that. And this is a picture that I took this week from a pump that we took out of a patient. And as you can see, there's a clot within the pump, and this is the kind of complications that you can encounter in ECMO patients, of course, and everyone is familiar with that. And then there's going to be, I think, in the near future, a lot of publications about coagulation and inflammation markers, and how we should interpret them and what it means for the patients for the outcomes. And then this was just as an example of a report from a group. This is mainly the Netherlands, Belgium, and then a center in Sweden and a center in Spain, I think. And they looked at 71 ECMO patients with COVID-19, and as you can see, the distribution is the same: 93% VV, and the rest veno-arterial or other. And what they see is that the number of mechanical thrombotic events, for example, is around 14%, and I think the ELSO registry talks about 15%. So there is a high number of complications, not only bleeding but also thrombotic events, of course. And these are the kind of reports that we will see soon. And what they did was they took 71 COVID-19 patients and they compared them with 48 non-COVID ARDS patients. And they compared not only the patients, but also the complication rate, and they couldn't find really a big difference between the complication rate and the mortality between the two groups of patients. And so they concluded that and you can see here the survival curves of both the light blue is COVID and the dark blue is non-COVID ARDS, and it's just similar at 100 days mortality. And so to conclude is that that is not only their conclusion but also my conclusion of the talk, is that ECMO is still a useful and a life-saving in COVID-19 patients. I think we should not stop doing it, but we should probably look at the indications. And it's a complex, unpredictable, and difficult patient profile that we are having, with at this moment a 50-50 survival rate. We have to learn the lessons for the next pandemic. Is that we have the databases, but we should do some research on specific topics and try to get the specifications right, the nomenclature of what we say, not only respiratory, but we say VV or VA. We have to make some decisions on that. There should be a little bit more cooperation between continents, probably, but they're all working out it. They're all working that out. We can learn to make strategic plans and centralize ECMO. That's one of the key things that I think is important. We should look at staffing and resource utilization, but we can fill up a whole day talking about that. So thank you very much for your attention.
Luke, thank you so much for joining us. That was some excellent information. Thank you for sharing. We have a lot of comments and questions in our chat room. One of the ones that we've heard a lot this entire week is about CytoSorb. Do you have any experience with CytoSorb? Did y'all use that in your ECMO patients? Did you see a difference if you did?
I haven't used it, and I haven't seen it used. Mm-hmm. And I'm personally, I think the CytoSorb is something that is useful in some cases, but I would not use it as like, okay, it's a COVID patient, he has to go on ECMO, so we're going to put in a CytoSorb filter in it. I don't think that's very useful. And the CytoSorb filter is not selective enough, I think. It takes away the bad cytokines, but it also takes away the good cytokines. So, and I don't think it evens out each other. I think for a part, you also do a bit of harm, but that's my personal opinion. But I'm still waiting for the first. There have been some reports, but there's no useful information on outcomes, because I think it is not the only thing it's not like the golden egg that or how do you call it? Like that will cure the patients, if you know what I mean.
I do. And the other question that they really wanted to know a lot about was how do you anticoagulate? Bivalirudin, argatroban, heparin, and how do you choose?
Here in Belgium, I think it's mostly still heparin, because we don't really have a good experience. No. Not enough experience. I don't say the experience is bad, but we don't have enough experience with the alternatives. Although I think from a personal level, it's interesting to see that there are less complications. There was a report recently comparing heparin to bivalirudin for especially ECMO COVID-19 patients, and they they reported better outcomes or less complications at least. I don't think there was a difference in mortality, but if you have less complications, then I think it's worth trying. One factor that we have to keep in mind in Belgium is the reimbursement. So if it's not reimbursed, we are more probably not using it.
So bivalirudin is not reimbursed,
I
or
don't think
agatroban?
I don't think for these specific cases. I
Okay.
should check, but we have a very low reimbursement for ECMO as a whole. Like
That was one of the questions that was popping up, is what was the
Yeah.
reimbursement for ECMO over there?
Yeah, so we like Belgium is next to Germany. In Belgium, we have for a VV ECMO, I think it's 1,000 euros, which is about $1,100 for a ECMO, and you have to put in everything. You know, you have to put in your console, not the console, but the oxygenator, the pump, and that is for 5 days or something. And then if you go over the border to Germany, there you get 20,000 euros for an ECMO.
Wow.
So
right.
Yeah.
Big deserves for me. Well,
Yeah.
thank you very much. I know everybody's wanting to ask questions. So Bill, you want to jump in?
Yeah, sure. Luke, excellent presentation. And thanks for summarizing information that is still coming through. I noticed a lot of the questions that are coming up in the chat session, and there are many, have been covered in some of our previous talks that we've had throughout the meeting. So I would encourage, because of time-wise, I would encourage many of you, if your questions aren't answered, to go back to the Sanibel 2021 YouTube recordings and go look at some of those ECMO sessions as well, because many of those have been covered, although I'm sure Luke could answer them if we have time to bring them up again. Luke, you know what I've found is it's interesting, first of all, that I see that survival rate versus mortality. Some speakers or some societies speak in mortality, where other report in mortality, where other societies report in survival. And sometimes it seems like that gets mixed around. Fortunately for us clinicians with COVID patients on ECMO, the mean falls right in around 50%. So there's not a huge difference. On the other hand, I've seen centers, or watched centers that are 10% survival versus 80 or greater than 80% survival with COVID patients on VV ECMO. I want to know, I think it would be great to address that. And I have an opinion on that too, but I'd like to know your thoughts on that.
Yeah, thank you. That's a very interesting thing to know. Like, for example, we had the webinar with the Joint Perfusion Task Force, and we saw the excellent results from that center in New York. And it's all about indication, because I think if you would take all the patients that were presented to that center, and if you look at that mortality, that would be, it's not fair to do it, but I want to say if you reject certain patients, then your figures will be higher, and that is exactly what the difficulty is. You know, they spoke about at one point they rejected a patient that was pregnant, and they didn't want to put her on ECMO, and I'm not judging that. That could have been a good decision, but we don't know the outcome of these patients. Did they survive or not? And in Belgium, it's very, very difficult to decide to not put a pregnant patient on ECMO. You want to avoid that, of course, but if there's no alternative, then you have to do it. And I don't think anyone would reject putting someone like that on. So the difficulty is that the numbers are different, but you would have to have a risk profile of the patients that you're putting on ECMO. And then you have to use scores to know if it is, still worth the while. because maybe you can put someone on ECMO and he or she will die, the patient will die, and then you would say we shouldn't have done it. But sometimes you put someone on ECMO and at the moment you put them on ECMO, you're like, okay, this is not going to work, but then they survive, and you don't want to miss those cases either, you know. And then a second thing that is important is that we don't have any reporting on longer term outcomes. Like you can say, oh, our patient survived and he left the hospital, he or she left the hospital, but is spending the rest of the summer in a revalidation, and the rest of her life sipping at a straw and not having contact with anybody, you know. And we don't see that enough. We only see the patients surviving ECMO and then going home, but we don't see the misery that is accompanying those people.
And it's not like we're not trying to capture that in some reporting. There just hasn't been that time yet. I mean, this has all been going on with COVID patients just for a year. I would also add that there would be criticism on programs that might be a little bit more aggressive on putting an ECMO patient, a COVID patient, on ECMO sooner rather than later, so that the patient isn't exposed to the deleterious effects of mechanical ventilation for longer periods of time. So the critics would say, well, they put them on earlier, so maybe they need to go on ECMO. Well, we've heard that same critic throughout the evolution of ECMO, but maybe it is wise to put them on sooner, to get them off sooner, so that they have a healthy life and they don't have the problems of barotrauma and the other pathologies related to mechanical ventilation in the long term. So it's an interesting topic.
Yeah, it is. And also you can maybe avoid ventilating patients by putting them on ECMO, and look at it the other way around.
And I think Dr. Brody talked about that eloquently on the first day, on that changing paradigm, the first day of the Sanibel program. So I see that as the future, actually. Yeah. Thank you.
Yeah, sure. And I sorry if I don't want to go through with this, but it's not only for COVID-19 patients, it's for every patient you put on ECMO. You know, the ECPR patients, you can have an outcome, dead or alive, but what does alive mean? You know, is it quality, or it's just spending 6 months on ICU and then dying anyway? So
yeah. What have you seen the average time? I'm sorry, Brian, but what is the average? I didn't see you speaking. What is the average time on ECMO that you've seen? I know Al Stammers, with his data in the AMSEC webinar, reported about 19 days with patients that were in the care of his company with specialty care. 19 days on VV ECMO with COVID patients. Have you seen differences in that? And if I missed that on your data, I apologize.
Yeah, I didn't report on it. It was somewhere in the last report I talked about. It said it, but I don't know by heart. But I think 19 days is pretty much the average that we can see here as well. It's patients can spend 3 to 4 weeks easily on ECMO before they are taken out, before they are weaned.
So that's interesting, because I think a lot of ECMO programs, you know, they think, well, if nothing's happened in 2 weeks or so, you know, maybe terminate the patient. But you're talking about the average of 19 days, and that's with a greater than 50% survival. So I think that patience is a virtue here, unless, of course, you know, the comorbidities and the neuro status has been deteriorated to a degree where there is no hope. But there are limited resources. And I remember, like back in the congenital diaphragmatic hernia days, we were taking patients off in 10 days. Later, you know, they were dying, later learning that it was 3 to 4 weeks sometimes that patients would survive. So we have to be very patient as ECMO programs to let that an adequate time period go, because the adult lung, under lung protective strategies, does take time to recuperate, and every patient's going to be different. So I think that's a really good cautionary tale to tell throughout this experience.
Yeah, I think also that we will see with the reports that are coming out that we just are going to accept the fact that ECMO is going to take longer, that we can put patients on ECMO longer, and that we have to find ways to do that with regards to anticoagulation or change out of systems,
Right.
In the early days of ICU, I remember, and I'm not saying I'm very old, but we didn't have oxygen, we didn't have ventilators for everyone, And we just had to decide as well sometimes we put someone on the ventilator for a few hours, and then we switched the ventilator to another patient because there was simply no ventilators for every patient. And I remember that we had one oxygenation saturation sensor for 25 patients, and then we just did our tour around the ICU. So maybe there will be ECMO ICUs where there's an ECMO for every patient to avoid putting them on a ventilator. So who knows?
It was an interesting topic yesterday from Bruce Fees. How has your blood supply been affected by the COVID? And Bruce basically brought up a good point where he feels like that blood transfusion from a COVID patient actually can get COVID from a transfusion. And how we only have like a 3-day blood supply in our country, whereas the Europeans seem to have a much broader blood supply in their areas.
I'm not sure if I can answer that. I don't know if there's a difference between Europe and the US regarding the blood supply. I've heard that there was that they were on the edge of having a shortage, but I don't know if they actually had a shortage, because we have stopped operating on patients as well. So yeah, I couldn't say anything meaningful about that. Sorry.
Have you heard the terminology long hauler syndrome, Luke, associated with COVID?
Mm-hmm.
What's your knowledge of that?
Well, I know that's, and I think everybody knows that some patients have long-term effects of COVID. And I remember I volunteered in a vaccination center, and there was this young lady. She was, I think, 23 or something, and she came to get her vaccination. And I'm talking like a few weeks ago. So that was in March, I think. And she told me that she got infected in March 2020, and it was only a few weeks, 2 or 3 weeks, that she hadn't felt any symptoms anymore. And she was on anticoagulants the whole time. And of course, she was afraid that with AstraZeneca she would get sick again, or have complications. And I don't know what the outcome was, but it's not always. It's very subtle. The long haulers, they just have it's not that they're sick all the time and at home, but they're just debilitated by. They have little bit shortness of breath. It's like you have a strained shoulder and it's always nagging you, and it's always there, but it's not. You can still function, but it's still there. And I think that in the long term, it's like when you smoke, you have lesser years to live, and if you have gotten COVID, you will probably, some patients will also have a stronger reaction to other diseases. And I think registries like the genomic trial can maybe shed some light on these long haulers. But it really is a problem, I think, for many patients.
Yeah, I think that it was like 18 to 20% had long hauler syndrome. And I actually know somebody very well that's been in and out of the hospital. They'll start feeling better, and all of a sudden the peripheral or the limb paralysis will set in, and they have to go back in for another, plasma, exchange. And yeah, so I think, these particular patients, their neuropathies, both, cerebral, limb, exhaustion, it's just like a cycle. It comes and go. It's very debilitating. You mentioned Dr. Kwan's lecture sometime back on the AMSECT webinar, and I remember him saying for patients that go on ECMO, VV ECMO, COVID patients, that their weaning process tends to take a little longer. They tend to be a little bit more conservative with their weaning process, because they've had a number of COVID patients come off ECMO only to have to go back on or deteriorate after that time. Do you remember that statement, or do you want to elaborate on that?
Yeah, well, I think the patients that are being put on ECMO are like really they come from a long road of ventilation and barotrauma, as you said, and they just have a longer. They also are longer on ECMO, so they need a really long time to get weaned. I can surely imagine that. We sometimes have patients that you would be like, if they would be, for example, from a drowning or something, or a less severe disease, you would be like, why is this patient still on ECMO? Very low tidal volume, very low gas flows, just enough. But if you switch it off, then they just completely crash. So yeah, that's certainly something that we see here. Yeah.
So the reason
that they just need that little bits of support to go through. Yeah.
So the reason I mentioned that is, in typical ARDS patients, it seems like we were able to wean a little bit more aggressively when it's time. But for the COVID patients, the clinicians are tired. They're saying, well, man, we're going to miss this window. We probably need to come off sooner than later. I don't know why they're waiting for a couple more days. Well, now we see some ample evidence to show that maybe staying on ECMO just a little bit longer, despite the X-ray looking better and gas exchange looking well, it might be a valid point with these COVID patients because of this slipping backwards sequelae that we're seeing in many of these patients. I'd love to get off ECMO when the time's right as well, but it looks like there's some backsliding with this type of disease. I remember you made the comment about it's not when we'll have to do this again for a pandemic. It's not if, it's when. We said the same thing with H1N1.
Yeah, but that's exactly what it is. And with regards to the weaning, and I think we're almost out of time, but with regards to the weaning, you also have to remember that there's especially in the first wave, we had a lot of patients coming in and they were standing upright. They were not feeling bad, but then it turned out they had saturation of 85 and their lungs were white and they just walked in the hospital. It's a very strange, unpredictable disease. And especially in the first wave, we saw patients that had a really bad CT scan, and that was the only symptom that they had. Like their lungs looked terrible, but they felt okay, So it's a very strange disease.
Luke, we have time for one more question. Brian, would you like to?
Yeah, I'm just going to try to summarize, some of the questions that I see online, but there's kind of a lot of questions revolving around just general differences between the US and Europe. Are you aware of anything else, that you're doing differently over there than what we're doing in the US? You covered some of this with the also Euro statistics. Is there anything else that's different, or you see it as better that they're doing in Europe that we're not doing over here?
Yeah, I wouldn't know, but I think from what I've heard from people speaking from the US, there's a lot of alternative anticoagulation used, more bivalirudin use in the US. Like I heard from some centers in New York and that they just switched to bivalirudin, like we're not doing heparin anymore. And I think that will also be the future of anticoagulation. Just need something different, and but for the rest, I couldn't tell you if there's any other difference. I think the treatment of ARDS is pretty much the same everywhere, and yeah, I wouldn't know. We only use centrifugal pumps. I don't know if roller pumps are still used in the US. You should tell me.
Not for adults, it's mostly centrifugal, but certainly in the neonates and the pediatrics, there's a fair amount of roller pumps that are still used, but not so much for adults, I would say, with the new, not the better technology that has come out in the last few years with centrifugal pumps.
Yeah, okay, good to know.
Well, Luke, thank you so much. We hope you enjoy your friends meeting up later in Belgium. So have a great one, and thank you again. Very informative.
Thank you. It's my pleasure. Thank you.
Thank you.
Good luck
Our
with the
next speaker doesn't really need an introduction since we all know him as the president of the American Board of Cardiovascular Perfusion, Bradley Cullott. He has over 30 years experience as a perfusionist and is currently the coordinator of perfusion services at Ann and Robert Lurie Children's Hospital of Chicago. He also is a triathlon, marathon, swimmer, house rugby, and makes all of us look bad here on the panel, just like the other speakers that have. I mean, you got to stop this, or either we've got to get more active, Susan. What are we going to do here? We got to do something. So
I think everybody get up and go for a jog around the room now.
I think we're going to have to, because we've been embarrassed this meeting with all of these things, and we're just sitting here eating bonbons. So thank you so much for joining us. We're looking forward to your presentation.
Thank you, Carla.
Whenever you're ready to share, feel free to go ahead.
Well, thank you for the kind introduction, Carla. I think you overdid it, though. I am getting old, so I'm not that much of an athlete anymore. So, but thank you all for inviting me again, Brian and Susan, for walking me through this. And Bill, looks like you have a magic hat on, Bill. It keeps on disappearing sometimes, the brim, and it's kind of funny to watch, actually. And Ty, good seeing you again. I really like to thank you for inviting me to this meeting, because this is like the first big meeting of the year, and it's really a good kickoff to like show everybody what we're doing on the board. As Carla said too, in real life, I'm a pediatric perfusionist. I'm just like everybody else. I basically work the last 10 out of 11 days, pumping cases every single day. So I hope everybody's case volumes are picking up, because ours certainly has. And with that, I am going to start the show. Hopefully I'll do this right. All right, so briefly what I'm going to do is just review the board examination challenges during the time of COVID. I'm going to explore the outlook of perfusion educational programs during the pandemic, and I'm going to look into the impact of the pandemic on the CCPs and review certification stats. I will also discuss advancements and enhancements of the American Board during the adversity of the pandemic. So what are some coronavirus actions and responses that we had? Well, last time I spoke to you at this meeting, we were going through a hurricane. Everything was unfolding at one time. We did not have very clear communication of what was going on with Prometric and the national testing centers. So the examinees last year were scheduled on March 25th to 28th. 62 examinees were already registered to take the exams at that time. And I kept on looking at the Prometric website and seeing centers closing. I became very concerned about this. And we reached out to Prometric on March 16th of last year. And they said, no, everything's fine. Everything's open. We'll get everybody in. Everybody will have their exams. Well, then suddenly the next day, they informed us all centers are closed. So this really left us in a lurch. And the American Board really took this to heart. We notified all the examinees right away. We considered other options. We even considered meeting at a hotel someplace and giving out a paper exam at one time, just to get the exam out and get perfusionists into the field. However, the best decision was to wait and just wait it out and let Prometric come back online. So on April 19th of last year, they told us that the exam will take place on June 17th through the 20th. And again, all examinees were contacted and rescheduled for June. They were also given an option if this is too much headache and too much bouncing around, you can reschedule for free in October, and we'll definitely get you in October. At the same time, we were notified by clinical rotations that a lot of clinical rotations were not accepting students anymore. They were sending them home. So we had to take action. We temporarily waived the 75 cases and the 10 pediatric observation requirement for the students. We just basically accepted on March 16th the cases as is. If you had 72 cases, that's fine, we'll accept them. However, we found out just through auditing students that a lot of them had all their cases already. So only a few of them were, a couple cases. So it really wasn't a big problem at that time for us. We thought it was going to be a huge problem, but it really didn't turn out to be. So we reviewed all their applications, and we basically stayed ahead of the pandemic by contacting Prometric and the students and about the fall exam. We also monitor the progress of summer graduates for any hardships in starting your career during a national crisis. These perfusionists have to pass their CAPES to become certified. So they have to take 2 exams to become certified in the United States. And a lot of state licensures and hospitals require you to be a CCP to practice. So we didn't want to hold anybody up. Oops. So the results of the examinations in 2020 were we administered 461 PBSE and CAPE exams through Prometric testing centers. The fall exams were on scheduled October 14th through the 22nd, and a total of 210 examinees earned their CCP in 2020. I'd like to congratulate, if anybody's sitting out there that took the exam, thank you for putting up with all the COVID changes, and congratulations. So this year, the spring exams were held on March 24th through 27th. There really wasn't any problem getting people in and finding a site this year, which is good news for us. So 39 examinees took the PBSE exam, 33 passed, and 62 examinees took the CAPE exam, and 52 of them passed the CAPE portion. So they will become certified. The fall dates have not been announced yet, but we will announce that very soon. We are also staying on top of educational programs. We don't want a situation that happened last year where all of a sudden, students cannot get their rotations, they can't get their cases. So we reached out to program directors, the PPDC committee, with Brian and Ed, and to have them survey all the schools and to see what is coming up. Are they short cases? Are rotations still closing? Are they back in the rotations? So only 2 programs responded of possible shortfalls in clinical requirements. One was an adult base, they just weren't taking any students anymore. There was a couple pediatric centers too that deferred their students for a couple months. However, a recent update that both of these programs expressed that they should meet the requirements, and they're back online. The students are back in the OR and doing cases. However, we were informed recently that one program might be moving graduation now a month back, and this poses a problem for us too, and for the examinees and the students, because now they're going to lose a month basically to get their cases to sit for the CAPE examination. So it might be tight for these students from this program that are going to be pushed back on their graduation date. This is not for sure yet, so hopefully they won't be pushing them back. What about the CCP? Well, last year we did send out a mass email to all the CCPs saying any recertification hardships faced by the CCPs regarding clinical cases or your professional requirements due to the pandemic will be handled on a case-by-case basis. And if needed, the CCP will be granted a filing extension at no charge until the end of 2020. And just to update you, everybody out there, that we did extend that to this year. And there's also an update. We did have a rule saying you could not have more than one extension in a 3-year recertification cycle. We all voted that this rule should not apply during a pandemic. So the good news is if you need an extension, you'll get it. But you have to notify the national office and go through the proper channels. You just can't sit at home and say, I want an extension. So you have to let us know. So let's look at our numbers and stats for this last year. So as I said before, and this is the annual report that was sent to everybody at the end of last year. So it doesn't reflect changes for this year at all. As I said before, the new certifications were 210 examinees. Conditional extended leave, we had 110, and there's an asterisk next to that for a reason. We're going to talk more about that in the next following slides. And we did have 131 on extension. The good news is our total certified is bumped up to over 4,500. And surprisingly, I was kind of wincing looking at numbers thinking we're going to get hit hard with people losing their certification this year. And 94 was not a bad number. So I was kind of shocked by that. And I think this is something that we're going to have to really watch this coming year or the next coming years to see the impact of what the pandemic has done to our profession. So just an overview, 216 CCPs initially signed up for an extension as of August 1st of 2020. As I said, 131 were on extension at the end of the year. And the average number of extensions is about 94 CCPs per year that file for an extension for various reasons, life changes, job changes, et cetera. So, we consider this always. And of the 131 extensions, 67 of the CCPs were still unable to meet the requirements by the deadline, and the deadline's at the end of the year, and were moved to conditional certification. So a total of 174 CCPs are in conditional certification right now. And the average number, for the last 10 years has been about 99 perfusionists per year are in conditional certification. And conditional certification is not punitive. It's just another way to make sure that people are staying active and keeping up with their cases. They shouldn't think of this as punishment, and that you are fully certified when you're on extension, you're on conditional, you're on extended leave, you are still a CCP. And we also have to consider that a lot of people do go to extension, then conditional, then to extended leave, and then they retire. It's just kind of a natural progression that it seems like people do when they're thinking of leaving the field. So we'll have to watch for any bump in retirement coming up in the near future. And the American Board does expect further hardships. I mean, as I said before, my caseload is going up, but we're still hearing of some centers that really aren't up to par yet. So the American Board will consider other hardships due to the pandemic and will make adjustments as necessary. And every COVID-related extension is handled on a personal and case-by-case basis. We do have a committee set up that handles all these cases, all these requests, and any hardships will definitely go to the committee, and we will definitely handle anything on a personal level. So as I mentioned earlier, there are 94 CCPs lost their certification this year, and about 85 is average for the last 10 years. And this is kind of, as I mentioned before, I was really kind of shocked by that. I thought we would have hundreds leaving the field, but it seems like the pandemic might be delaying life plans. It seems like a lot of people aren't moving around, and they kind of want to stay put. So they might be putting off retirement, or going to work for vendors, or leaving the field. So we'll have to definitely watch this. I know we had a new hire this year, and I was kind of surprised that we didn't get more applicants. We got a handful of applicants, good applicants, but I expected a lot more during a pandemic that people would want to move. So maybe people are staying put more because of the pandemic. However, the American Board did hear of some older CCPs that are be guided to retirement because of the COVID related decline in cases. I personally know of 2 perfusionists in the Illinois, Chicago area that were basically told, well, our caseload is down. How about retiring now? So unfortunately, they were kind of led to retirement because of the pandemic. And I just found this interesting article in the Chicago Tribune that as the COVID pandemic surges, so do Illinois teacher retirement. So, some professions are taking advantage of this pandemic and basically saying, okay, I'm done. This is too much. So again, we will definitely have to watch the retirement numbers. Big thing a couple of years ago was we all thought that people are going to be retiring en masse, and it didn't happen yet. So again, something to watch. Last 10 years of CCP growth has been very steady and upward. So that's good. Sorry about that. Got a little frisky dog in the background. Our gains and losses. So we had, as I said last year, 210 CCPs get their certification and 94 leave the field. I think it's kind of interesting to look at the graphs and see, as long as we keep a nice spread, I think we're okay right now. It seems like in 2016 and 17, we did get a little bit close, about 50, about close to going under. So I think we need to watch this more and watch our numbers more. I did hear that there are new schools coming online, and I did hear that a lot of programs are increasing their students, number of students in their programs. So we might be seeing a little bump in more students and CCPs coming online soon. So the big question is always retirement. Everybody talks about retirement or leaving the field. So when are you hanging up the clamps? Well, we had a survey in 2016, and 38.2 said their percent of perfusionists out there said they're within the next 10 years. In 2017, we did a survey with the ACPE, and approximately the same rate, 39.6, said they're going to retire within the next 10 years. Again, dates may vary due to factors such as the economy or personal decision or a pandemic. We did find out that the average workforce, almost 30% are ages 50 to 59, and 15.3% are 60 years and older. I was just amazed to see that there are some perfusionists in their mid 70s still practicing, and that good for them, kudos to them. I tell you, after a week like this week, I don't know how much longer I can last. We are doing another workforce survey this year. We have partnered with the AACP, and it will be included in your recertification period. So basically, after you recertify, you're going to be redirected right to a survey. Please, please, please answer this in good faith and don't skip over it. We really need this data. Our profession needs this data. You need this data. So please answer in good faith. And we will definitely look at the current workforce again in this survey and the impact of COVID-19. So this is really kind of a very important survey, and I can't stress it enough to please answer this in good faith that when you recertify this year. Again, our study and surveys, we can only tell attrition rates. The American Board can't analyze supply and demand. We just don't have any means to do that. So I think we're going to have to collaborate with other organizations or other means and other perfusionists who are interested in this to really analyze what's going on in the marketplace. We cannot estimate or predict complex employee marketplace demands or shortages. We definitely need other metrics in collaboration with other organizations and other people to hone in on what's going on with our community. But I think this is going to be evolving for the next couple of years, and I don't know if we should rely on a pandemic bump or decline as a metric for the future. The big news this year is we finally released our new online filing system. So it's streamlined, efficient, user-friendly. It's multi-platform system. So you can be on your phone and download your case. You can use it on your tablet, your computer. It's universal on any device that you use. And we are having an ongoing commitment to improving the online filing system. To me, even being on the board for the last 10 years, I always found the online filing system kind of slow and clunky and took too much time. So we have really dedicated ourselves during this pandemic year, a little time where we can have a little breathing room and see what's going on to improve some things with us from the electronic background and to ease the CCPs that are filing and entering their professional activities every day. We did have a few hiccups with this new system. Again, the IT company that we hired, they got affected by the pandemic too. They had to close their office. They had to have people work remotely. So it wasn't the quickest thing. We planned on a really quick turnaround within 6 months, and it didn't happen because of the pandemic. There's also been a lot of problems with the transfer over of data from the old system to the new system. The old system was not really keen on details. So if you live on a street and if you put ST, that didn't really transfer over to the new system. So we had a lot of variations and they had to fix a lot of files, but they had to transfer over 5 million files. So huge amount of data, and a lot of it had to be corrected to fit in the new system, and it took some time. So we started off with the soft launch, just kind of get it out there and see how it goes, get input from CCPs, and we will be having some online education soon, and meetings like this, we will be briefly talking about how to do this. So again, there are instructions online how to do this, but we will come out with something more intuitive soon that everybody can look at and walk through the system. So let's take a little bit of a look at this new online filing system. The first thing I'm going to tell you is there's mandatory user updates with the new system. You will first need to reset your password. And please do not use your social security number. In the past, we've had people enter their social security number as their password. Don't do this, please. No system is 100% secure, so please don't do this. You will then need to update your personal profile page, and you have to annually sign your electronically information of authorization of release of information to your designated authority in case you're audited, and the ethical statement that you'll have to sign. Just to note, Internet Explorer is not compatible with the new online filing system. So take your phone, but a lot of hospital-based computer systems are Internet Explorer based, and just remember it's not compatible with the new online filing system. So your dashboard is the first page you'll go to after you update your profile. This is basically your home page, your landing page. It's a main navigation page. There's profile updates if you move or change your phone. You could do it all there. It also shows your clinical and professional activity, your filing history, your password reset. You'll no longer have to call into the national office to reset your password. You can just do it right here online. Help too, if you have any questions about this new online filing system. I know it's going to be a little bit of a learning curve here for everyone, including myself. Email the American Board, and that we will guide you through it. And payment, it actually stores your credit cards if you want, and it also accepts PayPal. So here's a look at the dashboard. And one thing I really like is that it shows you how many cases you entered, how many CUs you have already. So it's a running tally. It's no more of kind of counting the numbers and looking at it and, do I have enough? It basically tells you that you have enough. And this will stop counting at 40 cases because that's the requirement. There was some thought on the board to actually have the CCPs enter all their cases, and that would give us a better determination of what's out there. But I don't think I wouldn't want to enter every single case that I do. And I think that's a little bit too much to ask right now, but it would be good information. If you notice at the bottom here too, there is a link to an instruction sheet. The instruction sheet is also found on our website, how to contact us, a CEU calendar, and SDCE calendar. Don't forget meetings like this for the perfusion.com meeting. Anytime that you are approved for category C1, category 1 CEUs, you will be on our calendar. You'll have like free basically promotion on our calendar. And if you need to see, if you're doing your professional activity report, hey, I went to a perfusion.com meeting, I can't remember the dates, you can click on that and it will show you what dates it was. So how do I enter a clinical case? Well, you click the box next to Add Edit on the clinical activity, click Add New. You'll have to enter your hospital information first. And once you do this, your information is automatically saved in a drop-down list. So the next time you do it, you don't have to type it all in again. It's automatically saved. And it's not like the old system where you had to go into a separate entity, enter it or edit it, and then bring it over. So it just remembers it on this page. And sorry, I cut off the bottom of this page. You'll have to say who your designated authority is in case you get audited. And again, it is automatically saved. You will enter your case date, your surgeon that you work for, and your case category. Was it a primary case? Was it a secondary case? Were you instructor on this case? It's all in a drop-down list right there. One big change that we made this year, the type of case is no longer required. So if you did a triple bypass, AVR, it doesn't matter. Again, we're only asking for 40 cases. Anybody can put anything in there if they want to. When I first became certified 30 years ago, I used to enter the toughest cases I did that year, thinking, oh man, I'm going to impress the American boy by this, heavy load of cases. This data is really not looked at by the American board. So we all decided that this is worthless information. We don't do anything with it. The CCP can enter any data they want to. They can pick and choose any case they want to. So it's really not indicative of what they're doing. So we got rid of that. What we do and are very interested in capturing is a case category. Were you the primary perfusionist? Was it an ECMO case? Was it a VAD case? So for your 40 cases, we are interested in the category. What category are you using to recertify? So this is the part that's really important to us. Not really particularly if you did a triple bypass that day, but the case category is important to us. You must click submit to save the case. So just don't leave the page, hit submit, and then it goes into your record. And your dashboard will reflect, yes, you added a case. So how do I enter professional activity? Well, basically the same way, add edit, add new, and then you will choose your professional activity. I could not capture the drop-down list, sorry, but if you wrote a paper, gave a lecture, attended a meeting, it basically all appears on this drop-down list. You will just click next, and you'll say the event type, the meeting type, the date of the event, sponsor, location, title, and the amount of CUs that you earn from that. And again, you'll have a running tally of everything on your dashboard. So how do you finally say, okay, I'm done, I reached my max, and I'm going to submit? Well, you hit the submit button. You'll get a printout or an on-screen notification of everything that you've done. Everything that you've entered will be on this report. I did blank out a lot of stuff on the top because that's all my personal information. So I didn't want to announce that to the world, but you will get a sheet that looks like this, or a page that looks like this. You'll click next, and then you'll be redirected to the payment page, and you will choose your payment method. Again, PayPal. We did hear a lot of comments from perfusionists. Why do I have to enter my credit card every single time? So it does save credit cards now. So it gives you a little bit better options here. So what's the future of the online filing system? Well, as I said before, this is something that we're really devoted to. We really want to listen to the perfusionists out there and saying, what can make this easier or what can be improved here? One thing that we'd really like to do is partner with AMSA, Perfusion.com to, make professional activity reports kind of auto-populate. Maybe a QR code that you can give for every lecture or signing up for a meeting. Once you register, you'll get a QR code. Click on your phone, goes right to the online filing system, automatically populates it. So this is some technology that we're looking at and considering for the next update. But after this first recertification period, we're really interested in this to see what perfusionists think, what can be improved, and we know it's not going to be 100% what everybody likes. So we are more than willing to make changes and to listen to the community on what we should do next with this. We're also thinking about making app-based communications from the ABCP. So your online filing system will have an app in it that will have surveys, information, notifications, communications. So this is something that we're currently thinking about and working on right now. So we can offer surveys to organizations or to companies and send it out to all the CCPs or those who will accept a notification on their phone. We're also thinking about ways to store your certificate and license on your phone too, on the American Board webpage. So if your employer needs to see your certificate or your license real quick, you'll have it available in your hand all the time. Again, please tell us what you think. It's not going to be perfect. We don't expect it to be perfect. So, we value your input and we'll work on improving this for all of us and make it better and easier for us to enter all of our information. What else have we been doing this last year? Well, we have active subcommittees to investigate and address and collaborate with other organizations. We did start a ECMO, VAD, New Technology subcommittee. And as I said before, we have a COVID subcommittee that looks into any effects of COVID via students, the CCPs, the impacts on our cases. So again, this committee is devoted to you. And if any problems come up, it goes to the subcommittee right away to handle any problems with the COVID situation. We also added, we heard from the community, we added ex vivo organ perfusion is now primary clinical case. There was quite a few perfusionists that reached out to us and explained this more to us and why it should be a clinical case. And I've never done ex vivo, but it seems like, number one, really cool. Number two, it does seem like it takes a lot of time and a lot of energy and a lot of knowledge to do this. So it's definitely should be considered a primary clinical case. We're always working on exam development, and we constantly have assignments to write more questions. So our question bank is huge right now. But we did focus on ECMO and VAD questions. We fortified and updated a lot of our pediatric questions. Technology changes and techniques changes, so we have to look at everything from the exam and weed out old questions or get new references for questions. And we really worked a lot on updating a lot of the pediatric and ECMO questions. Again, we added many new PBSE and a lot of new CAPES this last year too. And all of us have CAPE assignments for the summer that we have to complete for the students. So a lot of new questions coming out and a lot of good work by the people on the board. And for the perfusion community too, if you think you have a good question that you'd like to ask a student, you can submit it to us. We'd be more than appreciated to vet out the questions and references that you'll send to a question. And you can have your question be asked to students. So we welcome that too. We did, everybody knows we do authorize clinical simulation centers that meet our criteria for having case credit for a simulated case. So this is another avenue where if you're short a few cases, you can go to one of these simulation centers and do a simulated case, and it'll count as a secondary case for you to stay certified. It's also a great way to keep up with your skills too. So, but for these 12 simulation centers that we have throughout the United States, there's certain criteria that had to be met from us to be approved for clinical cases. They can still do stuff for CEUs, that's fine. But if they're going to have cases, they have to meet our criteria and standards to be authorized for clinical cases. Again, it's another good avenue for perfusionists to learn and to keep up with their case credit. And you can see our website for more information on the simulations. We also are very proud of this honor that we have for perfusionists with 20 years or more dedicated service. It's a CCP Emeritus, and we currently have 655 CCP Emeritus, and it's a really nice thank you to your service, and they get a nice certificate and plaque. It's really a thank you for everything that you've done in the perfusion community and for your patients. We also added an in memorandum section to remember the CCPs have passed and come before us. And it's actually humbling to look at this list and to remember some of these people. You know, you might not have been best friends with them, but you might have seen them at meetings and in the hallway or at the bar and shared a laugh. And it's good to remember these people, and they should be remembered. So if you look over the list on the website, if we're missing anybody, please let us know, because we want to capture everybody and remember all the CCPs that came before us. We do have more big news coming this summer. Unfortunately, I can't tell you about that right now. So this is, still early in the spring for us, and we have some other big news that's coming out soon, and some changes that are coming up soon. And stay tuned. That's all I got to say. Again, the American Board will constantly monitor the COVID-19 crisis and effects on our profession and our educational system and the individual CCPs. The American Board will adapt to make any necessary certification changes during this difficult time. And in a tough year, the CCPs have continued to advance despite the adversity of this continuing pandemic. And I really thank you for all your hard work and patience with this pandemic. It's just, we've been asked to do more during this time. It's just uncanny to hear the stories of the perfusionists, what they're doing, from proning patients to giving wellness checks to employees. They're asked to go above and beyond. But that's what a perfusionist is. A perfusionist is always the person you rely on to go above and beyond. We're not just somebody in the background. We are an essential part of the team, and we will do anything for our patients and for our employers that we work for. I just want to thank you for your time, and thank you, and stay safe.
Bradley, thank you very much for the update.
Sure.
But could you give us a hint about what's coming? Just a little one. Come on.
Well, I don't know if I can.
Okay.
Yeah.
All right. Well, then on a serious note, we had an amazing keynote speaker a couple of days ago who spoke about mission trips. One of the questions that we got repeatedly is, if our perfusionists from the America go on any of these mission trips, would this count as a case with the ABCP?
Absolutely. Yeah, 100%.
Good to know.
Again, all
I
you
didn't
have
know
to
that
list,
one either.
Yeah, all you need to list is the date, the surgeon, and the case category. That's it.
Okay.
Yeah, that's fully acceptable.
Wonderful.
Yeah.
Brad, one thing I wanted to investigate with you guys is on the old website, you had like an XML system where you could import cases.
Right.
Does that still exist on the new, platform, or is it going to be different in some way?
Yeah, Brian, hopefully it's going to be easier. It's not going to be an XML. It's going to be a CSV file. So it's going to be easier to do, because I use the XML file too to download my information. And it was clunky. I mean, it was if you got one thing wrong, the whole thing didn't work.
Is there a
So-
new like area where they have the specifications like published for that so that we can make sure that we follow that? We have like a lot of people in our company that use that because it's kind of built into like our EMR system, if you will. So
Right. I'm pretty sure it's on the instruction page there.
okay.
Again, this is kind of a soft landing
Launch.
with the new online finance
Yeah.
system. So, it might not be fully capable as of right this minute, but we want to make sure by the filing deadline that it is, you can do that. And I
Okay.
will definitely put that on my list to verify and make sure that it would be done by June by recertification time.
Okay. Thank you very much.
Yeah, but I'm glad you use that because, it always struck me that why can't we do it electronically like that? And
Well,
I'm
it certainly makes it a lot faster, when we do it that way. It's, you might have to adjust a few things here or there, but it's better than
Right.
putting every case in manually for sure. So
right, exactly. Yeah, I'm the one that pushed that, and we made that XML. So, but
Right.
XML is, it's clunky. So, hopefully the CSV will be much better and much easier to do.
Hey, Brad. It's Bill
Hey, Bill.
Harris. How are you, sir?
Good. Yourself?
Good, doing well. Really enjoying your talk, as we have in past years. Historically, I've had obviously a dubious relationship with the American board in the past, but like I've always said, bringing you into leadership has really brought clarity and some refreshing air to some of the old paradigms that I think the American board stuck to for a little longer than probably they should have, especially with like ECMO type cases. So again, I really appreciate your leadership and the changes that the American board have been making the last 5, 6, 7 years. Really appreciate it. So thank you for that.
Sure.
With comments that came in, two people said they were having problems updating the required fields, that they were not updating. I don't think I've had any issues with that, but do you want to check that as possible a glitch for some people at some point? In other words, the new system does not update the required fields. And I don't know what they're talking about. So just some
Okay.
feedback.
Yeah. And to those of you out there that are listening to Bill's comments from what he said, please contact our national office with any problems you have. If you find a glitch in the system, please contact our national office immediately. I filed at the beginning of January when it first came out. So I was the first one to do it, and it went smoothly for me, but now we're hearing about some bumps like Bill just said. So please, contact our national office if you do have a little speed bump there.
The other question I had is, well, I got so many, but that's me. But we have other panelists on the field.
I got all morning, Bill.
Yeah, do you? Well, we have to get you off at 10 o'clock.
Right.
But we get a lot of requests for foreign perfusionists to find out how to get certified in this country. And I know that's been an obstacle for a number of years, and it's a huge hurdle for so many different reasons.
Right.
If we continue to have a real national shortage with schools closing, schools opening, or increased demand for working ECMO, who knows what caseload's going to do heart-wise. Is there any other windows that you see in going forward for entry of or simplification for that kind of thing for foreign perfusionists? I know it's a huge hurdle, and possibly the American board isn't the one that needs to drive that.
What you said last is probably the key there, Bill. So we require that you have to go to an accredited school, and it has to be approved by the ACP and KHEP. So that is the linchpin there. You have to, if you want to be an international program, if you're in Europe or something and you want your school to be certified and to take the American board exam, they should apply to the ACP and become accredited. Then their students can come and take the exam. But right now we need an educational standard. We need to guarantee that these students are being educated in a proper way. And it's a level playing field, and there are set standards to education. So to just say, I'm going to take the American board exam, and you went to some school, someplace, there's differences in education. And then, there's I'm sure their education in Europe and throughout the world is good, but some aren't.
But
And
it is possible for a foreign school to be able to meet that standard
yeah,
and do that.
absolutely. All you have to do is apply. So
Okay.
there, I'm on the ACPE committee too, and there have been talk throughout the years from foreign programs saying we'd like to become accredited. And it seems like they never pulled the trigger though. It seems like, okay, we're going to do it, we're going to do it, we're going to do it, and then never do it. We've had centers in India, Saudi Arabia, that have been interested in doing this and just never did it. So it's going to happen. It's going to happen sooner or later.
Are there specific hurdles there that make that, challenging for them, from the ACP side, or?
There is. Your clinical instructors have to be a CCP. That's one.
Okay.
Number two, site visits. You have to visit the program. So that means these international programs are going to have to pay somebody from the ACP to fly over there and inspect their programs. However, times have changed. The pandemic has actually been good in certain areas too, where, we are doing site visits virtually now. I must say it's not as good, because one aspect that we like about site visits is actually talking to the instructors, talking to the students. So, that's a little bit lost, but all the paperwork and everything like that can be done virtually. So it could be a short little trip to Europe or wherever. I'll volunteer and definitely go over and site visit someplace throughout the world. But it's going to happen sooner or later, Brian. And I hope it does, tell you the truth, because it should.
I just don't see where the incentive is for the schools to do that, because why train their own people and then have them go to another country?
Right. That's part of the problem too, but they keep on asking us to do it.
So maybe it's a carrot for their schools to be able to have that possibility of having that arrangement.
Correct. Yeah. So that's something that definitely will happen and hopefully improve care for our patients and set a standard throughout the world.
Thank you very much, Bradley. That's very good.
Sure.
Very informative. We have quite a few more questions on here, trying to get through them all.
Sure.
Some of them had said, I did reapply in January after your new program was put to use, and it seemed much easier and very, very good. There's some other glitches that said that Colin Crenton said that over 30 cases he already submitted and they're already missing. So there are still some glitches that need to be
please again contact our national office for any of these questions. Please contact our national office.
Get that call in. Okay.
Because
another one too that's always been asked, and I think we ask you this every year too, is some people think that it's still archaic to have the 40 cases requirement. Do you think instead of just contact hours and that sort of thing, do you think the American Board will ever make that change?
I don't think so. We actually get people writing us emails saying 40 cases is way too few. It should be more than 40 cases. So, we got to eliminate all these little programs and it should be higher. So there's both sides that we're dealing with here. I don't really think so right now that we're going to change that standard. The contact hours is intriguing, but also if you work for a place with a really quick surgeon, you're going to be working a lot more to get your cases, right? If you're only doing singles and, if I'm doing an ASD, I'm on pump 20 minutes. So, there's both sides to that argument. Again, I was not involved with the initial choosing the 40 cases. And it always seems like it's a hot potato, what you should do with that. You have people saying it should be more, it should be less, it should be case hours. So right now, I think in the middle is pretty good.
For my own ignorance, Brad, what is the update on how many cases for like 8 to 12 hour ECMO shifts or some of these other standby cases for TAVRs and mitral clips and everything we're doing? How many of those now can go toward the 40 case minimum?
15. ECMO can. If you're sitting ECMO, you can that's a full case. So, if you're setting more than 6 hours, that goes as a full case.
Right.
VADS VADs go for a full case. If you're asked by our definition is, if you're asked by a surgeon or a physician, hey, this is a potential case, I need you to stick around. That's a standby case. You can document that.
Right, but how many, let's say I only do ECMO, can I still be certified and turn 40 ECMO shifts in?
Yes.
Okay, so it's not 15 ECMOs, but everything else has to be in the OR.
Correct. Yeah, so you can fully certify using ECMO, and some people do. It's not that many that do, but some people do. And that's why I said the case category is very important to us. So we want to see what you're using. We don't care about what type of case it is. We want to see what you're using. Are some people going ECMO and standby, ECMO VAD standby, purely bypass cases? So that's the categories that we're interested in. But yes, you can be fully certified just doing ECMO.
So the 15 limitation is really for standbys and
correct.
What other services? 15?
It's mainly
OpCab, like
OpCab,
HIPEC also is standby, right?
No, HIPEC now is a full case. So
HIPEC is a full case. Okay.
Yeah,
okay.
so,
That's maybe a new change then, huh?
That was last year, I think.
Okay.
Yeah. So just a minor case like that, you can. It's a standby case. Again, everything's online, so you can look at the case categories and the definitions of what's in the case category.
Perfusionists are lazy, so I'm glad you're verbalizing this. Plus it's recorded.
Right. Well, Brad said. Yeah, but please, the website will definitely spell that all out for you. I'm sure I'm missing some cases, some standby cases that you can use. And don't forget, you do get credits you use for being a clinical affiliate. And we bumped that up last year to 3 per year. So it's a good perk to, number one, mold the future, and number two, to get some CUs for that.
Can you explain how that works exactly?
So a clinical affiliate is you sign up with a educational program, a perfusion school, to become a clinical affiliate. You just have to basically sign an agreement, and like our hospital requires a contract and insurance from the program, and then we get students. And once you get students rotating at your center, you can get CUs for that. So all you have to do when you recertify, say, on that drop-down list and professional activity, instructor, boom, you name the school that your instructor at, and you will get CUs for that.
Hey, Brad,
And I highly recommend being a clinical affiliate too, because we teach students from Rush University and Midwestern, and I believe education's a two-way street. I learn from my students as much as I teach my students, and it's really, as I said, molding the future. You are molding the future with these students, and I'm staying on top of my skills by being an instructor too. So I highly recommend it to everyone.
Absolutely, and it's a great opportunity to interview these students to see if you might want to hire them, or they might want to come and work with you too. So I think that's
absolutely
great opportunity. And you're right, it does keep you sharp, being a clinical instructor too, because they're sharp.
Right, they are sharp.
Very much so. Hey, Paul Shuttleworth had a question too. He said if there's any information on how many students that apply to different perfusion schools that are turned away because the schools can't take any more students. Do we have any numbers or data on that?
I think you have to contact the ACP for that specific details. And, I think that actually boils down to that individual school too. So they'll probably refer you to an individual school, how many they turn away. Yeah, we do get, we get reports from the schools, so it depends on each program, how many they accepted and how many they turned away.
Mm-hmm. And I think that's based on clinical sites too for the schools. A big problem for them, I think too. So, like you said, if there's any place that would like to be a clinical site,
Right, or me. 'Cause I'll point you in the right direction. So
That's right. That's right.
yeah.
Hey, Brad,
Yes.
Douglas Drogemer would like to know if he's covering 3 ECMO patients in a day, why does that count as 3 cases?
Why doesn't it count as 3 cases?
Why doesn't it count?
We've had a lot of discussion on this, and there were some centers that were covering 5 to 7 ECMOs at one time. We do not feel that this is a safe practice. That's why. So we value the 1-to-1. Sorry, but
No,
I do think it's important and safety feature and good
See, I
patient
didn't know
care.
that was the ABCP stance that y'all promoted the 1-to-1. I did not know
Right,
that.
and that's
Okay.
what we do.
Well,
yes.
that makes total sense then. I
Right,
did
because-
not know that.
Yeah, and it was debated, hotly debated for many years that, it was getting a little crazy what some people were sending us, and 5 to 7 ECMOs at one time. Like that can't
That's
be
a
good for
lot.
anyone.
Uh,
Not good for the patient or the perfusionist.
yeah.
We're seeing a standard like around 1 to 3 maybe at the most. But I agree with you, and I think it depends on what kind of patients you have on ECMO.
True.
So I actually like the board stance on promoting the 1-to-1 ratio, because oftentimes, you're taking care of 3 patients, but you're there and it's the same VV and all that kind of stuff, and like people will take advantage of that. So I actually like the promotion of 1-to-1, although in reality, 1 to 3, 1 to 2 is become the standard. Any more than that is just abuse, in my opinion. At least that's what I'm seeing as an evolution with labor
Right.
force.
Right. Yeah, I think safety is the utmost importance. So we have to consider that.
Yeah, 1 to 3 is fine till 1 decouples. So I've been there, done that, did that about 3 weeks ago. So I
Right.
Well, hopefully you don't have
Oh,
3
geez.
decoupling at the same time.
Nope, thank goodness. So
Right.
I stand behind you on that. Well,
People
Bradley,
wanted
do
to-
we have any more questions for the
People wanted-
ABCP?
Yeah, people wanted to know if slides were available. Now, I know we have recordings, so they can always do some screenshots, but a lot of people are interested in some of the statistics that you showed, and I don't know if you make those available or not.
Well, it's available on the annual report. So you can look up the annual report on our website. It might not go into that much detail, but it's there. And you can refer to this recording too.
Right. The other last thing I wanted to say, unless we have 4 minutes before our next keynote speaker, is one thing that nursing has done, especially with COVID, but despite COVID, has had compact licensure, where 34, 35 states, if you're licensed in one state, you have reciprocity in other states. And we're seeing that trend, especially in nursing, some in perfusion, of more travelers. Part of it's financial incentive. Part of it is just, getting out of the politics of one hospital. I know licensing falls outside the American board jurisdiction. I know respiratory wants to entertain this. So if you wanted to travel to different states, you didn't have to continue with licensing through each specific state that you're going to travel to. I wonder what your stance might be on that as far as perfusion is concerned.
I know that our national office does deal with licensure boards all the time. They are constantly referring to us because one caveat of being licensed is you have to be certified. So we are being contacted by licensure boards all the time. There has been, during the COVID pandemic, there has been a lot of reciprocity with licensure between states. However, that depends on the state. You get some states that are very stubborn. They don't want to do it, like Illinois, just won't do it. So it really depends on the state. I'm sure if there's a national outcry, we could probably lean on state legislators a little bit more to say, we need this done, especially in a pandemic or in a crisis situation. But it seems like a lot of states waived, their requirements for licensure and allowed licensures from other states to be used in their state, except for some states like Illinois.
Again, it was temporary, but would the board promote that? recommend that to the states that you're involved with?
I think we would, tell you the truth. Again, I'm only one person, but I think we would. I think it should be. I think it's a good idea because we do have a lot of people that are transferring jobs, and I got to wait for my state licensure for 3 months. This is ridiculous. So, we do have a lot of that. And why should somebody wait to work when they're fully certified and experienced and licensed in another state? So I think we would support that bill. Again, I'm one person, but that depends on the other 8 people on the board. But I think it's a good point, and I would definitely promote that.
You may be one person, but you're a big person.
Funny. All right. Well, Bradley, that is our hour. Thank you so much for joining, especially on a Saturday morning when your dog obviously wants to go for a walk. So thank you so much. Really appreciate it. And we're getting a lot of good feedback on your new website as well. So thank you.
Great. Well, thank you, Carla. I always enjoy speaking at this meeting. As I said before, this is like a kickoff, and this is like the introduction to the year for me. So,
Wonderful.
Hopefully I'll see you next year.
Next year in person.
Yeah, good.
Yes.
Well, thank you so much for inviting me again. I really appreciate it.
All right. See you next year.
Bye-bye. Thank you.
Thank you. All right. Bill is going to be taken over as moderator right now to address our keynote speaker. So, Bill.
Yes. It is with my pleasure that I am introducing my next speaker, who is our keynote. I'm going to change hats for this for a certain reason. Maybe I don't have it on backwards. It's hard to tell on the screen. Anyway, we all have those teachers in our lives that we remember, even those that we may have had an positive effect on us during our youthful years. Well, I can say without hesitation that our next speaker, Mr. Dumont, has had one powerfully positive effect on me, even in this so-called twilight of my life. Yes, he has been an important part of my acting career as a mentor, but more importantly, he offers his life philosophies to all his students that are fortunate enough to work with him. And this helps me in my medical career for sure. I am lucky to have him so close here in New Orleans. Mr. Dumont has more than 30 years of experience in acting and over 150 major film and television credits. Films include Spencer Confidential, Trumbo, Dallas Buyers Club, Jurassic World, Catch Me If You Can. His television credits include The Righteous Gemstones, that I believe he's filming now with his son, I think, Blue Bloods, Magnum PI, The Good Fight, and American Horror Story. He currently coaches over 200 actors on Zoom from as far away as Italy to San Francisco and Maine to Florida. He is a tri-coastal actor and residing in New Orleans, New York, and Los Angeles all at once, and he shows no signs of slowing down anytime soon. He's always on to new projects. James has offered his spare time in offering his presentation entitled The Story of You: How to Unlock a Greater Sense of Self, Manage Stress, and Thrive. Ladies and gentlemen, my coach, friend, and superb actor, James Dumont. James, if you want to come on screen with us and unmute yourself, or are we having any issues? Brian, can you turn anything on? There he is. Unmute yourself, sir.
Yes.
Now let's start over. Now you got it. Good, man. How are you doing?
Well, I was going to say Wild Bill Harris with the earlier cowboy hat, but now we've gone into a different. G'day, mate. Like you got a nice little bowler hat going on. I appreciate that.
Well, it's another character that you've helped train me for. So
this is true.
And thanks for joining us in your hugely busy schedule today.
No, it's good. This is an interesting time. My son is, as you mentioned, my son is in Kirtley in Charleston, South Carolina. He plays Pontius Gemstone on the Righteous Gemstones, Danny McBride series, John Goodman's grandson. And he's doing 7 out of 9 season 2, and I'm going to do, looks like now 5 out of 9 episodes this season. I don't start till June. But yes, so my wife and my son are away. It's just me and the dog. who I was like, wait a minute. So talk about walking a dog. As soon as we're done, we're going to go take care of the dog. But thank you, William, for that lovely introduction. I want to just start out by, I know this is an odd thing for an actor to be kind of talking to perfusionists about how there might be tie-ins between being a perfusionist and some of the skills in which that I've had to use and encounter. But so I'll just present as much as I can and let you guys decide what you find to be most applicable to you. But one of the biggest things is, as Bill had mentioned, I've been doing this for about 40 years and about 150 movies and television shows. And I've probably done about 10,000 auditions, at least, probably maybe 20 to 30,000. That's a lot of job interviews. And in the time period, one of the two things that I think two stories that I think are really kind of applicable to kind of bring into what I want to really talk about today is unlocking the story of you, and why that may or may not seem like an important thing in terms of what you do. I do think it's important for us to be present and for us to be able to be great listeners. And, we're in a world where we have much distraction. There's an immediacy to information. We're being bombarded all the time, emotionally being pulled in many different directions. And I think the key to that is really being present and being able to assess and evaluate, as we used to say when we were doing auditions live, come in and read the room, because, I'm out in the lobby and there's things that are going on in this room that I'm not aware of, but I have to come in with an intended result. And I think the most important thing always is looking for the best or the greatest outcomes. And I think that's where we have a lot of things in common. And there may be things that, unbeknownst to us, that we're walking into these rooms, we don't know what the energy is. And I think sometimes we come in and we have to kind of handle certain situations and be ready to adjust. And I think that has to do with really being present, really being available, and being able to listen. And I think listening is it actually is the hardest thing in all of acting, to be quite honest. Saying the lines and creating characters are actually very, very easy for someone like myself. But man, listening is extremely difficult. And so there are a few things that I'm going to kind of talk about today that really kind of strengthen and highlight ways in which to be present, ways in which to assess and evaluate current situation and kind of the energies that are there. But more importantly is to make sure that that we're not bringing in, as we used to say in acting, it's like, the actor's job is to come and solve the problem. They're trying to find this particular character for this story. And so the actor's job is to really solve the problem. So you're the solution to the problem, but you shouldn't bring in more problems. Come in and solve the problem. Don't bring in your problems. And the stress and strain of having, no job security and maybe doing, 5,000 or 100 auditions in a given year and maybe have 5 to 10 jobs can kind of wane on you a little bit in terms of your contribution. But I think it's a matter of really staying present and focused and being able to learn and watch clearly read the room, as we like to say, read the room. So 2 stories that I think I want to start out with that kind of like bring me into all the things that I want to discuss today. One is, there was an opportunity. One time I was doing a film in Louisiana with Eva Longoria and Billy Bob Thornton, a movie called Baytown Outlaws. Fun little movie, kind of like it's like a Southern pulp fiction, good old boy Southern fiction, pulp fiction. And the way that shot was set up was that there was a cinematographer on a crane that was 50 feet up in the air, and he had what's called a Steadicam, which is a kind of camera that makes it look like a human being is kind of watching. And the idea is that this director wanted to have this all done in one shot. So this 40-foot crane is set up, out in Lafayette, Louisiana. I think we were in Hammond, Louisiana. And the idea is that you can see at a distance this police car coming all the way up the road. You can see the dust and the gravel, and they had spent, I don't know, I was sitting in a trailer, a mud around me trailer for about 6-8 hours. They had spent all this time to set the shot up. And the idea is that he'd be at the top of the crane would come down, someone would unlock the harness so he would be safe. And then the camera operator would then step off the crane and then follow behind me on my shoulder. We would turn around, say our few lines, and then the camera would then get behind me and go all the way in for one shot and end it with the person in an ambulance. So this is a shot way at a distance that they spent 6 to 8 hours, choreographing and working out. And then it's my job to kind of come in and make, I have, 3-4 lines with an actor from Vampire Diaries. So they had spent, a good half of the day getting this shot together. And sometimes I liken what I do to being these days, I liken to what I do being a closer in baseball. For those who are baseball fans, the closer is the pitcher that comes in at the 8th or the 9th inning, and whatever the score is, we want to make sure that we close this game out. So there is a great deal of stress and pressure put on because, if they're spending 6-8 hours, some people are making $300, $500 an hour, to set this whole shot up. And we want to get it all right. So, and all done in one shot. There's no internal cuts. That's the whole point of it, because it's the last shot of the movie. So they spent all this time. I'm called out to the thing. I get there. I walk up. Everything's going well. Crane comes down. They unstrap the camera guy. He comes around. We say our guy passes me. We say our lines. Camera switches around over my shoulder into the ambulance. Boom, done. One shot. Everybody's looking around. And the director's like, that was perfect. That was fantastic. It's like, what? And I go, well, that's why you call me. I've been doing this a long time. It's all up to me. I can't let everybody down here. And so he said, okay, well, let's do it. Let's do another one just so we have another one. And the point is, and then more recently, I'm recurring on a show called City on a Hill on Showtime. The Kevin Spacey is not Kevin Spacey. We don't talk about Kevin Spacey anymore, but no, Kevin Bacon. Kevin Bacon was also directing the episode, and because of COVID, this was a remote location where they not just spending 6 to 8 hours, they had spent multiple days having to lock the location up and cleaning and making it very safe. And so what ends up happening is, got at 5 o'clock in the morning. Same situation. They clear out the entire set. The director and the other actor and myself, we do one little rehearsal around 6 o'clock or so. We start shooting around 7 o'clock. We do 3 different camera setups, 1 to 2 takes each. By 8 o'clock, they're done. They had spent days, weeks, months delaying it. Even we were supposed to work in 2020, we moved it into the next year. And then to be able to come in and really kind of deliver in a crucial kind of moment, because time is money. And all the kind of risks and liabilities of putting more and more people on set. So I was really able to kind of, for all that work, all my work was within a half hour, but there were many, many people that spent a lot of time to do that. And so why I bring those 2 stories up is that, and you guys can decide how much that is applicable to the work that you guys do. But I feel like, having that kind of preparation, being able to, the key things in terms of my work, I always say to actors, and I think this is a key thing for anyone now, is I call it the Holy Trinity, which is relaxation, focus, and concentration. And being able to increase your ability to relax, to focus, and to concentrate will always, in my experience, of 150 sets and, and thousands of auditions, and now, teaching for well over, 20, 30,000 hours, is relaxation, focus, and concentration. Anything you can do in your everyday life to increase your ability to relax, to focus, and concentrate will always lead to a positive outcome at some point in time. And when there is so much at stake, as you guys, what you encounter is, people's lives are at stake. So the ability for you to stay relaxed, focused, and concentrated at crucial moments, making sure that you listen and assess the situation, These are same skill sets that I use every day in terms of my teaching and then in terms of the auditions that I do every day. So a few things, there's a great technique that we have in acting called the Meisner repetition exercise. And the repetition exercise or game was developed by Sanford Meisner, who is a renowned acting teacher at the Neighborhood Playhouse. You can look up his work. And what he did is he actively trains actors to be active listeners and to pay attention to their stage partners. Repetition is the foundation exercise of practical aesthetics, which is an approach to acting that was developed by playwright David Mamet, who is also a well-renowned director and writer, a screenwriter, and W.H. Macy, which most of us know from Fargo or from the TV show Shameless. And traditionally, actors, shocking, you'll be shocked to hear, traditionally, actors do not listen well to each other. They rehearse a scene in the same way throughout an entire rehearsal process, so they know what's coming next. This means that their skill must be in pretending to respond truthfully to something that they've heard hundreds of times. Repetition of information sometimes gives us a complacency to, yeah, I know that already, but still people need to be acknowledged and people need to be heard, and you still need to be present. And so that's where this exercise comes in. Sooner or later, your performance will degrade over time because you stop to listen, working either on film or television. The point and the purpose is to remain spontaneous, night for night, performance for performance. Meisner's view is that the practitioners of practical aesthetics, actors should listen and should not set their performances in stone. In the words of Mike Alford, they should be different every night. If your performance is truly spontaneous and immediate, meaning based on what is happening here and now, rather than copying what has happened or been rehearsed before, then you must learn to work off the other actor and doing this in the moment. So repetition helps you build the skills to deal with this new spontaneous and immediate style of performance. Repetition is very simple. I'm going to tell you the way the exercise works. Two actors will sit in a chair opposite one another, and they will look straight across from each other. Now, mostly now because of COVID, people have been doing this in Zoom. It's been a little bit more difficult, but I think I've been finding Zoom to be actually quite intimate and impactful in terms of people's focus and concentration in terms of the work. But repetition helps you to build this skill of being spontaneous. Repetition is simple. Two actors will sit across from one another. They will look straight at each other and say something truthful about the other person. Now, this is something that people can do at any particular point in time. It doesn't have to be actors, but the idea is the purpose is to stay present and available. So what you do is you say something truthful about the other person, and then that person repeats from their perspective and continues to repeat what you hear until something happens that make you change it. For example, one person may look at another person and say, "You're unsure." And the other person will repeat and say, "I'm unsure. You're unsure. I'm unsure. You're unsure. I'm unsure. You're unsure." The idea is to repeat it in order to really hear it, in order to listen it and to stay present. There's no need to do anything. There's no need to change what you say or how you say it unless you see something. If you see something, say something. Sound familiar? Unless you see something that new that occurs, this keeps you present and focused in the moment. Simply put, if you see the person fidgeting, biting their lip, you may believe that they are nervous. Then say it and continue to repeat it until one of them has something new that occurs. For example, "You're unsure. I'm unsure. You're unsure. I'm unsure." You see them biting their lip. "You're nervous. I'm nervous. You're nervous. I'm nervous. You're nervous." You hear them go, "Ugh, you made a mistake. I made a mistake." And they go red. "Oh, you're embarrassed. I'm embarrassed. You're embarrassed. I'm embarrassed. You're embarrassed." As David Mamet says, invent nothing, deny nothing, This means that you do not need to change anything on purpose, but you need to see a change in your repetition partner. Then say it, don't deny it. Remember, it's invent nothing, deny nothing. There are 3 rules to this repetition. 1, to tell the truth. 2, if in doubt, repeat. Don't think, just repeat. Stay in the moment, stay present. And 3, don't stop playing the game. Keep playing it until you get it right, get it wrong, completely mess it up. Or if a herd of gazelles tramples through the classroom, keep going. Place your focus on your partner and play the game until you're told to stop. You must allow yourself to be influenced by the other actor and inadvertently at this stage influence their behavior without attempting to do so. This game has no winner. It is not a competition. When you make a mistake or get stuck for words, just attempt to keep going. Your worst mistakes are gifts to your fellow repetition partner and will keep the game going. Simply saying that what you see, say what you see, regardless of social politeness. Miser used to say, forget being polite. He actually said a different word, but he said, forget being polite. He was a big swear word person like myself. He doesn't mean to be maroon. He simply means that if you are an actor, you must be open to live truthfully. This is the way we work as actors. Living truthfully under imaginary circumstances and scenarios. For this reason, the actor must be unrestricted by social niceties in order to prepare for this. It's not about being mean to each other. It's about being open enough to each other to see it and to respond it. Now that kind of ties into another thing, another concept that I think is extremely important that helps to kind of unlock being present and available and maximizing what you have to offer. And it's a concept that is a psychological concept called mirroring. And this kind of really is a kind of a bridge from the repetition exercise of being present and listening, not setting a result, but really being there present and listening and assessing what's going on. And it's called, it comes from Heinz Kohut, who was a therapist who had the concept of mirroring. I want to talk about that a little bit because I think being able to mirror or match people in the moment and in certain situations is very important. To be properly mirrored, to be properly seen and heard. If you are not being properly mirrored early on or consistently, it is hard to find the right mirror for you to properly see oneself. This concept comes from Heinz Kohut, to be properly mirrored. Now, this is where things get a little bit kind of deep in terms of the work that we do as actors or as human beings in general. If you are not being properly mirrored early on in life, then you are constantly for wanting, needing love, attention, approval. Then you get into what we call compensatory behaviors. Examples are various addictions, sex, drugs, alcohol, overeating, makeup behaviors, such as shouting, constant need for attention, or overcompensating. I am therefore not internalizing the acceptance of who I am. The good behavior I have done thus far, it has not been met, matched, or mirrored. I won't even see it in myself. If someone didn't see me as I am, how am I going to learn to see it myself? Until I meet the somebodies or the someones to see me as I am. The teacher, the coach, the therapist, the priest, the mentor, the boyfriend, the girlfriend, the husband, the wife, the brother, the sister, the grandparents. The potential to undervalue yourself is immense and always there at many steps along the way in your life. To look and take great care and to look and to take a great deal of courage and intelligence. It takes a great deal of courage and intelligence to arrive where I am at. without having been properly mirrored or matched. So you need to remind yourself that. Mirroring is a type of psychological transference where others serve as a mirror that reflect back a sense of self-worth and value. Just as people use a mirror to check appearances, mirroring transference involves the use of affirming and positive responses to others to see positive traits within oneself. Mirroring is a really, it's kind of a key thing, because what ends up happening, I call them emotional, we all have emotional potholes in our life. Certain moments in our life, there are people that have not mirrored or matched what we have needed and wanted at crucial moments. And what happens is, if that's not mirrored, met, or matched, then we do find ourselves getting into compensatory behaviors of sex, drugs, alcohol, overeating, overcompensating, inflated egos, overreaction, what I call, I had a reaction, it was a great word for reaction. But my point is that we need to make sure that we're taking care of and addressing these unresolved emotional potholes. So one of the most interesting things that came about in the last year that I've been teaching on Zoom, and mind you, I've been an actor for 40 years, and I just started teaching around 5 years ago, and I always thought, oh yeah, people, teachers are people that can't do it, so that's why they teach. And so I had such a derogatory thing when I've had such amazing teachers. I've studied with Sanford Meisner, I've studied with a man named Larry Moss, and Bill and I have both studied with Larry, and a guy named Tim Phillips. But this last year in COVID during COVID has unlocked so many incredible things. And one of which was this thing that came my way from a woman named Lisa Greenfield, who is she's a palmist. She reads your palm and does tarot and also does astrology as well. And, that was more my dad's thing in the 70s. And I was like, yeah, okay. But there was interesting information that came out. And one of the things that she proposed to put together is called the 30-day compliment challenge. And I would welcome you guys to look and explore this, because I had no idea whatsoever that what could be seemingly this cute little hashtag trite 30-day compliment challenge, how deep and profound and interesting it was to resolve and to forgive and to move on from these the lack of mirroring and matching that happened in certain moments. So the way the 30-day compliment challenge works is this. For a 30-day period of time, I'd like for you to, if you so choose, to give yourself 30 compliments. And so each day in the mirror, and it's good to do it in your mirror while you're brushing your teeth, because hopefully you brush your teeth at least once a day, maybe twice, hopefully. And so the ritual of doing it, you won't forget if you're brushing your teeth. So we call it, it's like toothbrush love. We call it toothbrush love. So each day for a 30-day period of time, I put them on pieces of paper. You give yourself a compliment, and you put it and phrase it this way. You are, and then put in that word. And each day you look in the mirror and you say, like, for example, I'm looking at I have the last 15 days. The first 15 days are my apartment in New York. The last 15 are here in my studio in New Orleans. So day 16 of 30 is you are amazing. So you look in the mirror, you're brushing your teeth, and you go, you are amazing. Repeat it, you are amazing. And then own it, feel it, take that in. Next one I had is you are fearless. You are fearless. Own it, believe it, commit to it. You are awesome. You are inspiring. You are resilient. You are remarkable. You are unstoppable. You are undaunted. You are talented. You are brilliant. You are one of a kind. You are tremendous. You are unforgettable. You are funny. You're going to be okay. Was my 30th. You're going to be okay. And why I bring this up and why it's important is we all have had moments, and you're giving this compliment to yourself, because someone at some point in time in your life did not give you this compliment. They did not mirror you or match you or acknowledge you or hear you or listen to you. And when you give yourself this compliment, you have to forgive that person. We ask you to forgive that person, because if you give yourself that compliment, then you can close that chapter. You can't keep walking around asking someone to validate what I think is probably the most profound one of all the 30 that I did. You are enough. Take that in for a second. You are enough as you are, period. You're enough. You don't have to overcompensate. You don't have to have more money. You don't have to be overly educated. You don't have to show off. You are enough as you are. And so of these 30-day compliment challenges, you're giving yourself a challenge. You're giving yourself a compliment that someone did not give you. So you give it to yourself for the day, just that one day. It doesn't get to be too crazy, not too egocentric. Just take it in. But you'll start to realize that there's someone, if you really go deep and you really look closely, that compliment is because someone did not say something to you at a crucial moment. And why that's important is if you need to resolve those issues. You can't bring, as I said before, that you're coming in and solving the problem. Don't bring in more problems. Because you bringing in those problems or something that happened before you came into the room, or as we say, enacting the moment before, you bring in those problems, you're not hearing, you're not listening, because you're still working what happened before. You're not present, and someone's life can be at stake. No one's life's at stake when I'm going into these rooms. So that's the best part about what I do. I'm just creating a human being. But my job, as I see it, is to make sure that I'm unblocking what I would be emotional blocks in order to be able to really hear and to really listen and to really do that repetition of the person in the room, is to be present and to read the room. Another really great a challenge that I recommend to you is to unlock your kind of emotional life, because I know probably in the medical field, emotion is probably frowned upon, because perhaps the emotion would be able to cloud your ability to be able to discern and make important decisions, perhaps. But I believe emotion creates reality. Your emotions are very, very real, as we found out in this last year. People's emotions are quite real. And so one way to kind of open up and unlock emotions is in my acting world, for audition preparation, I usually kind of focus on 4 basic emotions. It's happy, sad, angry, or scared. Those are my 4 basics. But I broke them down into 10 different emotions. And in the 10 different emotions, I have positive emotions and negative emotions. So the positive emotions are love. Some could say love is not an emotion, but I beg to differ. Joy, happiness, hope, and surprise. So love, joy, happiness, hope, and surprise are 5 positive emotions. 5 negative emotions are anger, fear, disgust, sadness, and loneliness. Why these are important are another challenge, if you so choose, is my new challenge now, because I like to challenge myself. I don't like to rest on any particular laurels. Usually these days, I'm as valid and as important as my next job. I've already done this job. I already got this job. So I already have many, many jobs, but I'm only as good as my next job, or at least somebody perceives me as such. So the next challenge we're doing is called the 10-10-10 challenge. Again, it comes from my dear friend, Lisa Greenfield, who I strongly recommend to look up. Her company is called Truth in Hand. And there's something quite interesting about how your hand or your fingerprints are almost like a deep telling of what is really kind of here is here. It's very interesting. I never quite believed it before, but then when I started to work with her on a quarterly basis, and she kind of helped to guide me in certain directions, saying, oh, these are the energies that are going on. Just be aware of this. Make sure you give yourself some rest. She scared me a little bit on January 6th. of 2020 when I was in Los Angeles for the Golden Globe Awards, as just going to parties. I wasn't a guest at the Golden Globes, but she read my palm and said, "Oh, here, be very careful. Be very careful with your traveling. There's something going around the world, and it is very, very devastating." January 6, 2020. There's no way that she was following the pandemic. Be careful if you're traveling, watch your health. But there's something going down that's going to be quite devastating to the world. And I go, what, like 9/11? She said, no, it'll be far more devastating and catastrophic than 9/11. It'll change the economic system. This is January 6, 2020. And I go, it's nuts. I get on a plane from Los Angeles. I'm going Southwest because I'm flying myself. Sat next to a couple who just came back. They're from Louisiana. They just came back from a cruise in San Francisco, first week of January 2020. I come home and I am sick. I never coughed this much in my entire life. I've lost sense of smell. I've lost sense of taste. This is January 6, 2020, with a couple coming off a cruise in San Francisco. If you followed the virus, there were some early cases from people coming off cruises in the first quarter of the year. So I bring that up because I go, little did I know, and I ended up in like 3-4 more flights, and luckily for me, I did not get COVID. It was quite surprising. There was no traces of it 6 months later though when I got tested. So the point is that this next challenge is called the 10-10-10 challenge. So what I'd like you to do for 10 minutes a day, or you can do one a day, or over a 10-day period of time. Pick one of these emotions of love, joy, happiness, hope, and surprise, or anger, fear, disgust, and sadness, and sit with that one emotion for a 10-minute period of time. Just sit with it. Turn the phone off, computer off, TV, just sit for a moment and think about what's the first person or situation that comes to mind when you think of love. Who's the first? What's the story? What do they look like? Who's the first person you think of joy? When it comes to anger, what is the situation? What is the moment in time? And you'll find that some of this 30-day compliment challenge and some of these 10 emotions are connected to each other. There are traumas or situations in our lives that have been unresolved that are connected to these emotions and connected to the lack of mirroring. But the 10-10-10 challenge is interesting because we don't really take 10 minutes out to kind of check in where we are emotionally. No one really asks us to do it. And we have tons of distractions. We have many ways to just, bide our time. But I think it's important to check in where we're at emotionally. And because my job as I see it is to kind of move aside and put aside the kind of emotional blocks that prohibit people from reaching their potential and from what I seemingly can be the most positive and best outcome. And that's, I think, what we always our endeavor in any particular thing that we pursue is the best and greatest outcome, and making sure that we don't do or say anything that prohibits or blocks our ability from being able to live up to that. I have a 17-year-old son who puts tremendous amount of pressure on himself to the point where it's kind of ridiculous. He's pulling a 4.0 at the Jesuit high school, which is one of the most 170-year-old Jesuit educated school in the South. He's also in another high school. It's a performing arts magnet. That's one of the biggest feeder schools for Juilliard. And he's also working on a television series, and he does boxing, 2-3 times a week. And he's like, I'm not living up to my potential. I'm like, Dad, and I go, hey, son, relax, you're 17. All your friends are vaping and have drunken parents, and they're just, they're asleep at the wheel and they're not paying attention, and you're doing fine, kid. You know what I mean? You're doing just fine. But I think what's happened is, we get ahead of ourselves, and very, very often we're not present or in the moment. And I think when you sit down for a 10-minute period of time and just allow yourself to go into and immerse yourself into, what that one emotion is, It's really quite amazing. You know, when I think of when the word joy comes to mind, I had a great aunt Edie in the Midwest, and she couldn't whistle. So she would make casseroles, and she had like a candy drawer, and you know what I mean? And she smelled of white shoulders. And every single time that I would go to her house, it was just this, her hand was very soft, and she was old. And so, and she would hold your hand, and it was the softest thing ever, the smell of her. And, she would make these lovely kind of Midwestern casseroles with, beans or whatever. And we just hated beans, but man, she made it, and that casserole was fantastic. So it's like, do you see how quickly we can assess and get to our emotional life? And our emotional life is important. I think we're being, these days, I have a big problem now of the word, the false branding of social distancing. It's not social distancing. We don't need social distancing. We need physical distance from each other in terms of safety, but we don't need to be socially distant. Socially distance has got us to where we are right now. So I'm really of the belief is that it's through the social using this social distancing, we've distanced each other, that we don't think that that other person has any of these anger, fear, disgust, sadness, loneliness, love, joy, happiness, and surprise. Every single human being feels these emotions, may repress them, may have to subjugate them in order to do what they need to do. But we forget how much that we've socially distanced from each other. So we need to physically distance, but we need to be socially connected to one another. And for me, the way in which that we connect is that emotion creates a sense of reality. It's when people's emotions have gotten out of control, or we don't acknowledge that the other person has a right to their particular emotion. But if we're in touch with our own emotions, 9 times out of 10, we're not projecting other things onto other people. So I say stay present, focus on your emotional life. It is valuable, it is important. And these compliments, I know it sounds silly, but man, when you start to sit down and give yourself a compliment each day in the mirror, either in the beginning of the day or at the end, you will be quite surprised how a sense of relief, because what that means is you have to forgive that person for not giving you the compliment. And it means you have to let that go. And sometimes it's hard for us to let go to traumas and to things that we have left unresolved or that we don't want to deal with. But there's something really deeply profound in being able to forgive someone. They may not even be physically alive anymore, and yet still their sense of loss or our loss or not being mirrored, met, or matched still kind of plays with us in some way, finds its way into our relationships, finds its way into our work, finds its way in the way we feel about ourselves. So as silly or trite or as egocentric as it may sound, it's okay. I give you permission. I would like for you to give yourself permission to give yourself a compliment and to feel, because that is one of the biggest human threads. Is I know there's such separatism between the things that separatism in terms of economics, in terms of education, in terms of race. But there's really one race, it's the human race. And the human race entails all of these 10 emotions. There's many subcategories, but these are the basic 10. And there's even more of a basic 4. So in that regard, I want to kind of close up a little bit, because I'd like to open up a little bit in terms of questions. I'm sure there may be a few. I don't mind if they're just, industry questions or about actors' process. But I think one thing I'd like for you to ponder as well, I've asked you 3 big things. I've asked you 30-day compliment challenge, 10-10-10 challenge. Got one more. I want you to sit down and think about 10 things that make you different, special, or unique. What are the 10 things you know about yourself that make you different, special, or unique from anybody else? Not in an arrogant way, but this is, I can say it. One of my things is I'm very generous. I don't keep track. I don't keep score. I just give. I give without any condition that somebody made. Now, mind you, I've been in situations where I've given and it's never been mirrored, met, or matched. So then I go, is it really worthwhile to share this kind of information or this knowledge or this experience or this relationship with someone that's not matching it or mirroring it? But one of my 10 things is that I'm generous in spirit. Recently, I started doing my on-camera workouts, and one of the most interesting things that I kind of pat myself on the back a little bit, I came up with this idea that, an actor Q&A. So every Friday I invite an actor in for a 2-hour period of time, and we just talk to each other about their process and their journey and the things that they're doing. But then I ask people to make a $25 donation for the 2 hours of this information, which some of these Q&As, I have like 50 of them. I've had Ed Asner, who is icon. I've had Michael Chiklis, Golden Globe, Emmy-winning actor. I've had amazing guests. I just had John Cameron Mitchell, who's you may not know who he is from Hedwig and the Angry Inch or director of the movie Rabbit Hole, but I can tell you a year from now, you will know exactly who John Cameron Mitchell is, because he's going to play probably the most well-known iconic character from 2020, and it's not Donald Trump. So my point on that is that I turn these little 2-hour conversations of sharing information and sharing knowledge into charity. And in the 10 months that I've done it, we've raised over $13,000 for charity. So it's been this thing where we're sharing information and we're sharing knowledge with each other on Zoom. People are taking notes and they have final takeaways of things. And we then turn that into a fundraising link. So we're able to, and this is charities that are like all over the world. Like next week will be the Wounded Warriors. This week is a thing called Burritos Over Bombs, which is a food bank in Mexico City. We've done it for LGBTQ community. We've done it for the Actors Fund. We've done it for cancer. We've done it for, Children's Hospital. We've, you name it. We've, 50 different charities. So being able to come up with kind of sharing information and sharing knowledge, but then having it have a give back to a charity. It's been remarkable. And Bill, I don't know if we're able to do this, but I'd love to try, we'll go into question and answer at this point, but one of the things that we do in my workouts, and I'd love to see if we can try to do it so that I can kind of at least get a sense of who everybody is here, is at the end of all my workouts, I've been doing these on-camera workouts, teaching people how to be more comfortable and understanding the frame. And we can talk a little bit about that because we have little time. But the point is that when I'm in front of a camera, I give it a big old hug because this is my world. So if you ever do presentations and you need to get in front of people, just remember that you're in a context of a frame. So the things that you deal with or see are all on the other side of the camera. I liken it to I have a picture on the other side of I'll show you my computer. On the wall here, I have my wall, my frame, and I have my notes. And so if you're ever going to do presentations, I recommend that you get to understand this is your frame. Your world is within your arms, is the world that's on the other side of this camera. But I want to open up the floor to any particular questions that anybody might have. But usually what we do, Bill, at the end of my my workouts is we ask people to go around and say, what is your one takeaway of all the things you heard in my speech? What's the one thing that kind of sticks out? If you feel comfortable and people want to do that, I think it's a great way, because I think any endeavor that we do, it's good to think about what's the thing that we really heard. Of all the things you heard, what's that one thing that sticks with you? And sometimes people may have say the thing that you heard, but maybe there's something else. It's up to you if you want to do that, or if we have time, or we can stay to questions. I want to respect the time you have, so I'll let you take it from here.
Right. Hey, man. Thank you so much. Thank you.
Yeah.
That's very inspirational. As with any talk, you have people that don't understand the correlation of why we put a presentation in, and you have many more that completely are tied into it. And we've had both on the chat window, but mostly the positive comments that have come back about life in general and the positive way, the inspiration you've offered us today is very much appreciated. I know, since I know you so well, we only have about 12 minutes, but we go into lunch. But since I know you so well, I want to let people know that James does a lot of reading with his Buddhist philosophies on life, on relationships, on people in general. Obviously, it helps him in his acting career, but it helps him with his students and with his relationships in his life, and to get over some of the past traumas he's had, as he mentioned, that we need to all resolve at a certain point in time. So, James, I would love to ask you to comment on that, but I'd also like to ask you, what do you do with negative people? As perfusionists or medical people, we always come across negative people in our lives. You do as well in the acting world. And I appreciate, because I've done acting and I'm a perfusionist, I appreciate that reciprocity, that
Yeah,
relationship.
I figured you'd understand the bridge between the two.
It's more than I ever expected.
Yeah, I think the one to speak to, I've been a Buddhist for well over 30 years. It's a form of Nichiren Shoshu Buddhism. I chant the words Nam Myoho Renge Kyo, which I can give you literal translation to, but it's like if I gave you the literal translation of love, yes, everybody's have a particular experience of it. It's an experiential practice rather than a philosophical or ideological. It's you experience it. But one of the ways in which that I can tell you in terms of Buddhism's been helpful is that on a daily basis, as I've talked to you before, I check into where my condition of life is in the beginning of the day. I chant in the morning and in the evening to check into where I'm at, so that I'm not easily moved or swayed. My condition of life may start out in a real positive way in the beginning of the day or not. And by the end of the day, I'm checking in again before I move on to the next day. And the point of that is that whatever we need to do to continue having a high condition of life so that we're not easily swayed or influenced, as you pointed out, by negative people. And to stay present and focused on the task. So that means you have to check in with where you're at before you kind of walk into a room. If you're coming in with things and they're coming in, that's where you're going to be butting heads. So I think the way in which is whatever you do in your everyday life to increase your, as I said, your ability to relax, focus, and concentrate, all three of those things are encompassed. But be mindful of where your condition of life is. This is why I know people will try to stay away and shy from your emotional life, and I think that's a huge mistake, because that's where we kind of run into problems in terms of dealing with negative people. And I've just finished having probably one of the most horrific experiences with the director on this television series, of which I've never encountered anybody like this before. And now, mind you, her circumstances that she was behind schedule and totally destroyed, messed up the cost the production $30,000 to $50,000 that day. So her mindset of her failure had a clearly, blurred our ability to have a communication between actor and director. But it was a horrific, awful experience, and I just let her vent her things, and I listened, and I did. This is an interesting thing for anyone who's done couples therapy. I'm big on the repeating, that whole repetition exercise I told you about. It's like, oh, Bill's like, yeah, I'm really upset about blah, blah, blah. Bill, I hear that you're upset about XYZ. Is there a way in which that I can help and resolve that for you? Repeat what the person's saying. I was really angry when you did blah, blah, blah. Repeat exactly what they said. I heard you say, right? This is what we do with directors, right? The director gives me a direction, and if I get a note or adjustment in an audition, director will give me a note or adjustment. It's like, I'll take a second. I go, I heard you say you'd like this character to be a little less angry and maybe a little bit more sad. Is that correct? Did I get that right? So just repeat exactly what they're saying. What it does is it diffuses whatever hostility, anger that's there. And that it validates that you actually heard what they said because you repeat it verbatim. Don't add another additional word. Any couples therapy person will tell you, trust me on that one. Don't add your slant on how you heard it, because that's not what was said. That's not how you heard it. So repeat. I think the smartest thing is to really, and as I said, we're all coming into various different situations. Read the room. If you're in touch with your emotional life, it's going to be so much easier for you to be able to see, assess, and evaluate what the real situation is. What the needs of the patient. You can see the patient is suffering or getting information that they're reluctant, and someone's trying to convince them to do. You're read the room, find a way in which to serve. It makes a joke of serving many masters. Being able, and I'm on set and I have to serve many different people. I have the light guy, the sound guy, the camera operator. I have a director behind a monitor. I have many people I have to serve in order for us to collaborate. It's about collaboration, and you have to understand what is your part of the street? What is your part of this collaboration? And one of which is to make sure that I'm not bringing anything in that hinders and prohibits the ability to stay present in this situation.
Beautiful. I think Susan's going to bring up some of the takeaways.
Okay.
Yeah, we had Carter had asked everybody one takeaway that we all have here.
Yeah, what's our takeaways? Let's hear them.
Yeah, and I think it's really important how you define our social and physical distancing and stuff too. I think we've done a lot of that social distancing.
We've done plenty of we don't need any more social distancing. We have to be socially connected to each other.
Yes,
the social distancing of family members and cutting them off and unfriending people. This has got to stop. We're not going to get anywhere, and we're not going to progress as humans. Period.
And even on the pressures that we put upon ourselves and on some of our family members, like you're talking with your son.
It's about physical distancing. Absolutely. Social distancing, we have to start reaching out, calling those people and reconnecting to them. I agree.
Kelly,
takeaways. I'd love to hear them.
Okay. Kelly had mentioned one about having an open heart and be present. I think that's very powerful.
Yep.
And Haas had said, be humble and look out for each other. I think that's really important also.
Yeah, I know there are certain folks, and I understand where it comes from, but I don't think this is an every man for himself situation when we all live on one planet.
Right.
I don't, wherever people fall in terms of their ideology, I do think we're all in this together, especially when it comes to having the planet and how we deal with it and the people that are on it. So I feel rather than every man for himself, I got mine and they're taking mine, and this is, we're all in this together. So let's figure out a way in which that we can kind of be mindful and respectful of each other's differences as well. I've just finished, I did a film with a group of people that I 100% vehemently, totally disagree with politically, but I can create art with them, because I think it's a sad commentary when we can't create a piece of art, even though we don't necessarily agree with each other politically. It's an important distinction. So I think, we're all in this together. Not every man for himself. I think that's anytime we start looking in that way, we make very short-sighted decisions about the human race. And I have children. I want this planet to be there for them. So we're all in this together. You have some other ones?
Yeah. Tina Leverance also said that change always starts within oneself.
Yes.
Very powerful.
Yeah. Yeah. I mean, if you're really looking for that big change, that's a, we don't coin this one, but on the Buddhist end, it's like world peace starts with you. If you don't have peace within your own heart and your mind and how you deal with your family and your situation, that if you don't have that, then you're going out and you're looking at the world in a whole different perspective. That's why condition of life is important, and how you maintain a high condition of life, because you can walk out that door and it's the same street. It's the same. I have the same construction going on in Louisiana since August. They still haven't done it. But my condition of life is when I walk out that door, what's my perspective and viewpoint on that? I come out sometimes and it angers me to know, and I come like, I really love my neighborhood. That's my condition of life. It's still the same place. It's that it is a mindset is very much a part of that. So whatever you do to keep that condition of life so that your perspective and point of view is present and be mindful that, okay, today, today I'm really angry about how they still haven't fixed my block. Every other street, but not my block, Any other takeaways from today?
Absolutely. We have them rolling in here.
Oh, wow. That's great.
Leo Carr says, be a positive mirror to yourself and to your team.
Yeah.
And then Josh Blessing, this is a great one. Read the room.
Read the room, man.
Uh-huh.
Woo, take that's for everybody.
And that is totally applicable in our profession.
100%. Read the room, bro. Don't come in with a big old agenda, man. To just take a second and just get some eye contact. What's the energy, man? Read the room. It's a good one. What else?
Sean Devereaux says, my biggest takeaway is to remember to be present.
Yes.
Everyone's life is busy, and smart technology makes us always look to the future. We should take time each day to remain present in the moment. Very good. Sandra Mohammed says, accept yourself and be open to others.
I am enough as I am.
Rita says, be the solution, not the problem. I've heard that so many times. Paul
I bet.
would always say that.
Exactly. Don't bring in, look, everybody's got problems. Don't bring in more problems.
That's right.
Come in and solve some problems, please.
Trying to see what other ones here. Michael Treat, he says, this has been refreshing, authentic, and really thought-provoking. Thank you very much.
It's 10 hours.
Awesome. We are good, right? Thank you so much, everyone.
Yeah, James, we've heard messages similar to it to some of our speakers, but the messenger, and you are the messenger. And I've been fortunate to have taken some of my acting classes with you, as well as some friendship talks. And I knew you'd be the right person to help us with our lifestyles and our ongoings and our jobs, for that matter. There's a lot of parallels that people will be able to take.
There were far more than I imagined when I was doing my homework. I was like, wow, this sounds very familiar to me. And I agree with you. Thanks. I like being the messenger, but it's really about the message too. So I'm just the messenger for the message, which is, we are all in this together. Read the room. You are enough as you are. And, emotion does create reality,
Yeah. Well, regardless, you're a great messenger as well as giving the message.
Thank you.
All right. So thank you again for your time.
Appreciate it. Thanks again. Bye-bye.
Thanks, man.
Yep.
Everybody, it's our lunchtime now. Let me schedule it for 11 till 12 Eastern time. And then this afternoon will be an exciting session. I remember when I was a fledgling perfusionist back in the mid 80s, my first presentation was actually out of the country. It was in Sweden and it was on ECMO, surprise, surprise. And I was so damn nervous, man. When they called me out of my street, I brought my carousel slides over to the AV person. It was a long time ago. We had slides back then, and I couldn't feel my legs. And I'm thinking, am I going to get through this or not? Well, I got through it. In fact, I probably rushed it because I had too many slides. Fortunately, and not a lot of people in the audience could understand English, so it didn't matter so much if I messed up. So that took a little of the pressure off. But anyway, this afternoon session, our last session after lunch at 12 Eastern, are some of our future perfusionists that are coming out of schools that have done some very, very passionate work in their studies and their research. And they're going to be presenting on some of their scientific findings. We've looked over them before and they're excellent. So please join us at 12 o'clock for some of these talks. There's also a survey that will be offered on the students because they get awards based on their excellence, and we are allowing the audience to vote on that. So we'll be showing that link later on with it. And anything else, panelists? Otherwise, we'll say bon appetit. Great. Thanks, everyone. See you in a while.
INVO's 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced INVO 7100 system provides innovative, next-generation improvements over the INVO's 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the Lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module, designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invo 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invo 7100 system provides innovative, next-generation improvements over the Invo's 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module, designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invo 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invo 7100 system provides innovative, next-generation improvements over the Invo's 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the Lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module. Designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invos 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invos 7100 system provides innovative, next-generation improvements over the Invos 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the Lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module, designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invo 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invo 7100 system provides innovative, next-generation improvements over the Invo's 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response, innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the Lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module, designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invos 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invos 7100 system provides innovative, next-generation improvements over the Invos 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response, innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
Welcome back from lunch, everyone. This is my favorite part of this meeting, and it's our Ken Farmer Memorial Scholarship. Do you guys remember the first time that you gave a speech or how nervous you were? These are our future generations that will be taking care of us. And I'm really excited to hear their research presentations. Now, we award the Ken Farmer Scholarship to a student, a perfusion student, who composes and presents an outstanding presentation for this meeting. And this scholarship will be in the amounts of $1,500 for first place, $1,000 for second, and $500 for our third place winner. Following their presentations, don't forget to please vote on the link in our booklet for first, second, and third presenter, and scholarships will be announced to these winners following their presentations. So our first speaker presenting and competing for the Ken Farmer Scholarship is a second-year Master of Health Science student in cardiovascular perfusion at Quinnipiac University. She originally hails from Boston, Massachusetts, with a background in preclinical surgical research at Boston Children's Hospital. Now, postgradually, she'll be beginning her perfusion career in pediatrics at Children's National Hospital in Washington, D.C. So please join with me in welcoming Madeline Warmer, presenting her research, Postoperative Effects and Attenuation of Circulatory Inflammation Mediators by Modified Ultrafiltration in Adult and Pediatric Patient Populations. And this is a meta-analysis. Please join with me in welcoming Madeline.
She might have hit her video button instead of her mute. There you go. And bring your video back on. Thanks.
Research in postoperative effects and attenuation of circulating inflammatory mediators by modified ultrafiltration in adult and pediatric patient populations.
Hey, Madeline, you want to hit your video so we can see you too?
Yeah, let me see if I can make that work.
Okay.
Let's see here. I'm not sure if it'll let me do that.
If you can see the window of yourself, it should be like there's like a pause button there.
It's just not saying available. That's all right. Might be a setting issue on my part.
Okay.
All right, let's see.
You can go ahead and start all over if you want to.
Okay, that's all right. Here, I'll get on to the next slide.
Sure.
Here. All right. The process of modified ultrafiltration, or MUF, was first described by Nike et al. In 1991, and this description of MUF was first applied in children as a means to more satisfactorily reverse the effects of hemodilution for the purposes of cardiopulmonary bypass, or CPB, which resulted in a rise in total body water with deleterious postoperative effects. Today, MUF post-CPB is a controversial practice in pediatric cardiac surgery and is rarely used in adult cardiac surgery, but overall is thought to reverse the therapeutic hemodilution and remove some pro-inflammatory mediators, resulting in reduced postoperative complications and mortality. So MUF evolved from the technique of conventional ultrafiltration, a commonplace technique during CPB, initially employed during the 80s for management of volume overload and hemodilution. This technique employs a hemoconcentrator device in line with the CPB circuit as a pressure-sensitive filtration mechanism. Application of a pressure drop across from the device forces plasma water and small solutes like potassium ions and inflammatory mediators into the hollow fibers of the device and out of the circuit into a collection system. Additional mechanisms of ultrafiltration have been developed, such as zero balance ultrafiltration, which utilizes conventional ultrafiltration procedures with volume replacement of normal saline, usually to create a pH balanced blood volume while using the hemoconcentrator to remove inflammatory mediators and potassium from the plasma while on cardiopulmonary bypass. Today, MUF is regularly employed in cardiac surgery patients in an arteriovenous or a veno-venous fashion, utilizing a cardioplegic delivery system with a positive pressure pump and or the patient's own native cardiac output. Many studies have evaluated the biological and chemical changes that result from post-CPB MUF in pediatric patients, and specifically interleukin-6, interleukin-1, interleukin-8, and tumor necrosis factor alpha have been found to act as pro-inflammatory mediators that are removed via the ultrafiltrate and have been well-studied biomarkers in the benefits MUF provides in pediatric patients. While adult applications of MUF are fewer, a study in 2000 by Grunfeld et al. Found that MUF in adult patients also significantly reduced cytokines such as IL-6, IL-8, TNF-alpha, and IL-2. Also adhesion molecules, which have been demonstrated to injure endothelial cells. The study, however, was unable to demonstrate any significant difference in postoperative morbidity or mortality from patients that experienced MUF post-CPB and those that did not. It's thought that other beneficial effects of post-CPB MUF are also related to increased hematocrit and attenuation of SIRS by reducing those inflammatory mediators, thus reducing edema and inflammation, and their effects such as leaky capillary syndrome, decreased lung compliance, increased chest tube drainage, and overall increased incidence of morbidity and mortality. Despite the kinetically assisted nature of traditional inline MUF setup, the procedure ultimately relies on the patient's own native cardiac function and blood volume. Because of this, there's a risk that improper initiation of MUF could result in exsanguination of the patient's blood volume into the CPB reservoir, or disturbance in cardiac function due to the displacement of a large amount of total blood volume. These risks are primarily associated with perfusionist error, which could result from improper clamp placement, especially during an arterioveno MUF. MUF procedures do also inherently expose the patient to an extracorporeal circuit and thus inherits the risks such as thrombus formation. So perfusionists must be vigilant in assessing the patient's electrolytes as well before, during, and after the procedure because of its removal of electrolytes and small solutes in plasma that could affect the patient's overall status. So this study hypothesized that post-CPB MUF reduces IL-6, IL-8, tumor necrosis factor alpha, all in the blood, and increases hematocrit, which provides advantages of reduced inflammatory response, decreased chest tube drainage, reduction in coagulopathies, and decreased blood transfusion requirements in both pediatric and adult patients. However, the increased susceptibility of the pediatric population results in decreased mortality and morbidity when MUF is applied, whereas no change is found when it is applied in adult patients, despite consistent reductions in chest tube drainage, blood transfusion requirements, and reduction in inflammatory mediators. The proven benefits of MUF in neonatal, infant, and pediatric populations undergoing cardiac surgery with cardiopulmonary bypass are thought to be due to the group's increased susceptibility to fluid overload, pulmonary injury, and higher hematocrit requirements. While the advantages in adult patients of MUF are less clear, the effects of the procedure post-CPB are similar in both groups. So the goal of this study was to compare and contrast both pediatric and adult populations that received post-CPB MUF to patients in both groups that did not receive post-CPB MUF. So a literature review was conducted via the Quinnipiac University Netter Library Network, employing search engines such as ScienceDirect, Google Scholar, PubMed, NCBI, AMSECT, and Perfusion.com. And searches consisted of randomized research studies, case control studies, retrospective studies, meta-analyses, procedural aspects, historical considerations, and other applications of MUF in post-CPB adult and pediatric patients. And results were examined for data points such as age, weight, blood volume, chest tube drainage, postoperative bleeding, blood transfusion volume, ICU stay, hospital stay, hematocrit, IL-6, IL-8, tumor necrosis factor alpha, and mortality. Adult subjects were over 14 years of age and included those undergoing coronary artery bypass grafting, valve repair or replacement, aortic surgery, and a combination of any of those procedures, while pediatric patients included as research subjects were undergoing cardiopulmonary bypass for repair of congenital defects and were under 14 years of age and 45 kilograms. Patients in both experimental groups will have undergone post-CPB AV MUF, and studies who utilized zero balance or conventional ultrafiltration were excluded from analysis. Also, studies including patients who were pregnant and end organ failure, had organ transplantation, or were emergently operated on were also excluded from consideration. Studies were evaluated and 17 were selected to be used for data extraction, ranging in publication date from 1992 to 2018 for a total of 1,665 patients analyzed. Data analysis was separated into two parts, the first focusing on post-operative patient parameters and the second part focusing on the immediate effects of MUF on hematocrit and pro-inflammatory mediators. Data from each of the studies was scrutinized for bias and inconsistency, and when accepted was organized into an Excel spreadsheet. Data from each study was separated under the author's name, study population, and finally into control and experimental groups. Statistical analysis was utilized to determine the values of mean, standard deviation, and range of each study parameter for each of the 4 groups evaluated. And student paired two-tailed t-tests were utilized via the Excel program to evaluate the probability that differences between the values in the study groups were achieved by chance. The calculated p-value was evaluated based on an assumption that a p-value of less than 0.05 demonstrates a rejection of the null hypothesis, in this case being that there is no difference in the modified ultrafiltration and non-modified ultrafiltration control groups in adult and pediatric patients within that measured variable. Evaluation of the analyzed data extractions and their statistical significance when compared was used to determine a conclusive relationship between and among the study populations observed in this retrospective meta-analysis. A total of 10 studies were analyzed in part 1 of the study, including pediatric and adult patient populations for a total of 1,322 patients. The adult patient population demographics from each study's MUF and control groups are summarized in table 2, and final analysis for the adults studied of part 1 are summarized in table 3. And the quantity of packed red blood cell transfusions was the only variable identified as significantly different between the MUF and control adult patient populations with a p-value of 0.03. Analysis was completed for 5 pediatric studies comprised of MUF and control groups for a total of 506 subjects with an alpha level of less than 0.05, indicating significance. No pediatric parameters were identified as significantly different between the MUF and control groups, and therefore the null hypothesis must be retained here. A total of 8 studies were analyzed in the second part of the study for a total of 345 patients. And the adult patient population demographics from each study's MUF and control groups are summarized in table 6. While final analysis for the adult studies demonstrated that hematocrit increase post-MUF was the only variable identified as significantly different between the MUF and control adult patient populations with a p-value of 0.01 displayed in table 7. Analysis was completed for 4 pediatric studies comprised of MUF and control groups for a total of 140 subjects. However, no pediatric parameters were identified as significantly different between the MUF and control groups, and therefore, again, the null hypothesis must be retained. The concept of MUF was originally utilized to attenuate the effect of therapeutic hemodilution for CPB during cardiac surgery on pediatric congenital cardiac surgery patients where they depend on high hemoglobin levels for oxygen delivery to avoid cyanosis as a result of their defects. The simplistic design is a basic pore filter that functions by selectively sieving fluids, metabolites, and molecules that meet the size and polarity requirements to pass through the hemofilter pores. The average hemofilter pore size is 65 kilodaltons, which allows any molecule smaller than that to be sieved out through the ultrafiltrate of the hemoconcentrator device utilized in MUF. Despite understanding the function of the hemoconcentrator and how sieving should work, it has been unexpected to discover that not all of the expected molecules are actually removed during modified ultrafiltration. These molecules should have a sieving coefficient of 1, where their size allows them to be filtered in the same ratio in which they appear in the blood. However, it's not always the case. Some studies, such as Clark in 1997, have speculated that binding of certain molecules, including cytokines, to larger proteins like albumin prevent their removal by filtration via the hemoconcentrator. And while cytokines such as TNF alpha, IL-6, and IL-8 should be removed in the ultrafiltrate because their molecular weights are below the pore size, it doesn't always appear that that is so. The respective molecular weights are shown in table 10, and the removal of many electrolytes in plasma water appear to be unhindered by this phenomenon, however, and MUF should then result in increased hematocrit. So after a complete analysis, a significant difference was found between the MUF and control groups for adult and pediatric hematocrit increase and adult blood transfusion requirements based on an accepted alpha level of 0.05 or less. Comparison of MUF and control groups for both pediatric and adult patient groups analyzed found no significant difference in sample size, respective group ages, 24-hour chest tube drainage, ICU stay, hospital stay, mortality, TNF alpha decrease, IL-6 decrease, and IL-8 decrease, as well as in pediatric blood transfusion requirements. A complete summary of the analyzed studies and their independent results and conclusions are shown in table 11. These findings suggest that MUF may attenuate some of the dilutional effects created by CPB and reduce the requirement of allogenic blood transfusion, but does not necessarily reduce the systemic inflammatory response mediators that are activated by CPB and their subsequent effect. The hypothesis being evaluated in this study could therefore not be accepted, and the null hypothesis is retained that there is no significant difference in post-op morbidity and mortality based on post-cardiopulmonary bypass modified ultrafiltration in adult and pediatric cardiac surgery patient populations. The finding of these analyses suggests that while some beneficial hemoconcentration may be gained from post-CPB MUF, there's no cumulative benefit by pediatric or adult patients that undergo the procedure. Specific indications for secondary effects such as total body water, myocardial edema, inflammatory response activation are not indicated by these results. However, they may just be out of the scope of this analysis. These findings do suggest that beneficial hemoconcentration from MUF procedures may result in decreased blood loss and blood transfusion in the immediate postoperative period for some patients. However, this requires more investigation. Despite an expansive search of the literature, there are very few recent studies evaluating the effects of post-CPB MUF and even fewer that evaluate its effects in adult patients. All of the studies included in this analysis were single center studies, all of which evaluated either pediatric or adult patients, not both. There also were no studies that evaluated all of the parameters analyzed in this meta-analysis. Most evaluated either physical parameters or biochemical parameters individually. So to accurately depict the non-biased results of post-CPB MUF, fully controlled trials must be completed in pediatric and adult patients within similar conditions of each other. And this type of controlled trial may actually be best displayed in animal studies where the surgical conditions are much more highly controlled than in human patients that are often quite sick before undergoing cardiac surgery. There's also less inherent risk to animal models under these stringent variable conditions than there would be to a human patient undergoing a questionably beneficial elective procedure. Subsequent human studies evaluating post-CPB MUF would be most appropriate in a randomized, multi-centered, blinded trial where the patient parameters and conditions will vary widely. All questionably related patient parameters should also be studied as they relate to MUF, such as hemodynamics, fluid balance, cardiac parameters, pulmonary function, biochemical change, edema, lactate levels, renal function, pharmacological treatment and interactions, and more that are excluded from the scope of this meta-analysis. Furthermore, medical investigation and comparative analysis of various types of ultrafiltration, hemoconcentration, and pharmacological treatments to attenuate, achieve the same desired result may yield a similar, safer, or more effective means than post-cardiopulmonary modified ultrafiltration procedure. And because protein binding may hinder the removal of cytokines and other pro-inflammatory mediators, they should be sieved off to reduce the systemic inflammatory response initiated by the CPB exposure. It's possible that further investigation may show similar benefits of increased hematocrit, resulting in increased oxygen delivery, decreased chest tube drainage, and blood transfusion requirement by conventional ultrafiltration during CPB, which may eliminate perfusion-related risk compared to MUF procedures. Thank you very much for your time, everyone. Is there any questions I can answer?
Thank you very much, Madeline. Great research. We only have time for one question, but I have a question. Are there any results that show indication for differing responses or outcomes for the VV muff versus the AV muff?
What I could find, the short answer is no. Basically, because you're treating a total blood volume, essentially you should see the same results over time. The VV muff tends to be displayed in research less frequently, which is why I chose to eliminate it from my research pool, simply because it allowed me to limit studies more specifically also based on cannulation. There are a few studies that even attempted muff-like procedures in ECMO patients, which would present more often in a VV fashion. So in order to help eliminate some of those studies and those options, I chose to eliminate from this study. However, anecdotally, no, it appears that the results can be kind of construed either way in VV versus VA muff.
Okay, thank you very much.
Thank you.
Our next presenter is originally from Southern California and attended BYU in Hawaii for his undergraduate degree. He is currently a first-year perfusion student at Rush University Medical Center in Chicago. And when Brandon is not in class or studying for school, he enjoys walking with his wife and their 8-month-old puppy, Charlie. Please join with me in welcoming Brandon Gertz speaking on ECMO as a bridge to lung transplantation.
Okay, thank you, Susan, for the introduction, and thank you, Madeline, for that presentation. So before this, Bill Harris was mentioning that as a student, he presented on ECMO, and I'm also presenting on ECMO and its possible use as a bridge to lung transplantation. And like Bill, I have a lot to say and I'm really excited, so I'm gonna jump right into it. So as you can see over the years, there has been an increase in the amount of lung transplants. And in 2019, there was an all-time high of 2,714 lung transplants. Although there has been an increase in the amount of lung transplants over the years, this hasn't met up with the demand. So we have seen a big increase in the amount of people on the waiting list. And although the donor pool has been attempted to increase through government efforts, this hasn't kept up with the amount of need for the vital organ of the lung. However, there could be a possible solution as the use of ECMO can be utilized as a last resort option to extend the patient's time to find a match. What is ECMO? I'm sure many of you are very familiar with ECMO, so I won't dive too much into the subject. But basically what ECMO is, it's an extracorporeal circuit that takes deoxygenated blood from the patient, oxygenates it, and returns it back to the patient. And there's two main types, which is VA ECMO and VV ECMO. And the purpose of my study is to explain the benefits and drawbacks to using ECMO to extend wait time for patients who are waiting a lung transplant. So the first article that I wanted to discuss is found in Cardiothoracic Transplantation, and it's titled, "Should Lung Transplantation Be Performed for Patients on Mechanical Respiratory Support, the US Experience?" And this research divides the patients into 3 groups, and they're divided on the support they receive before their lung transplant. So the first group is mechanically ventilated patients. The second group is ECMO supported patients, and the third group is unsupported patients preoperatively. It's also important to note that the patients that are supported by ECMO and that are supported by mechanical ventilation are younger in comparison to unsupported patients. Also, the propensity score, with the adjustment for propensity score, the hazard ratio was 1.5 for mechanically ventilated patients in comparison to unsupported patients, and it was 2.55 for patients on ECMO compared with unsupported patients. So essentially, patients that are supported on ECMO or mechanically ventilated have a higher risk for mortality in comparison with patients that are unsupported preoperatively before lung transplant. And this research was particularly interesting. On the right-hand side and the top right corner is a graph that depicts the survival percentage for unsupported patients in blue, mechanically ventilated patients in green, and ECMO patients in red post-operatively. So it shows their survival percentage after their lung transplant. And as you can see, the unsupported patients demonstrate a higher survival percentage in comparison to the mechanically ventilated patients and the ECMO supported patients. However, on the right side below that, there is a graph that shows the death percentage per year. And around 1 year, you notice that the death percentage per year begins to even out, and there's comparable results among all three groups. So this suggests that there's a high risk early phase for ECMO and mechanically ventilated supported patients 9 months post-operatively. However, after this high risk 9-month period, the outcomes are similar among all three groups. So an interesting takeaway from this article is that although unsupported patients have a higher likelihood survival post-operatively compared to ECMO and mechanically ventilated patients, once the 9-month mark is reached, they have similar results. Additionally, this poses the important ethical issue of if ECMO supported patients and mechanically ventilated patients are at a higher risk, then who should get the lung with the lung being such a vital and limited organ, and there's not a very large supply of such a vital organ. The next research that I wanted to talk about is found in thoracic lung transplant, and it's titled 20-Year Experience with Extracorporeal Life Support as a Bridge to Lung Transplant. And so this study is particularly interesting because it talks about ECMO-supported patients, and it divides them in three groups based on the year in which they received their lung transplant. So in the first group, we have 1998 to 2004, the second group from 2005 to 2010, and the third group from 2010 to 2017. I also wanted to highlight the bridging modalities that were used over the course of the years. So in 1998 to 2004, primarily VA ECMO was used as a support to lung transplant. However, as the years progressed, we see different bridging modalities, and VV ECMO was being utilized a lot more in more recent lung transplant candidates. Also, the type of transplantation has evolved as well, and that currently 47.6%, or almost half, of the lung transplants are whole organ, whereas in 1998 to 2004, only 9% or one individual received a whole organ transplant. And the results of this study are particularly interesting. On the right, we have a graph that depicts the survival probability among all three groups. The first era, or the 1998 to 2004 group, is depicted in blue, the second era in red, and the third era in green. So we can see a gradual increase in survival probability over the years as ECMO has evolved. And I wanted to point out particularly the 1 year survival probability for each group. So for the first era, it was 44%, the second era, 51%, and the third era, 77%. So we've seen a significant increase over the years in survival probability among these patients. So some key points from the article are, as more patients were bridged to ECMO, in the first group, only 11, and then in the third era, up to 70, we have seen a decrease in waiting list mortality. So as more people are put on ECMO on the waiting list, less people are dying on the waiting list. And a constant improvement has been observed with patients that are bridged to lung transplant by the support of ECMO. The last article that I wanted to talk about is titled Active Rehabilitation and Physical Therapy During Extracorporeal Membrane Oxygenation While Awaiting Lung Transplantation, a Practical Approach. And this is found in Critical Care Medicine. This article is interesting in that it's a case study that talks about 3 patients with end-stage respiratory failure, and it talks about how ECMO was used in their rehabilitation process before their transplant. So the healthcare professional team decided to cannulate the patients with a double lumen Avalon cannula, and they inserted it in the right internal jugular vein. And this was important because it allowed the patient to walk, and it assisted in their rehabilitation process because they weren't cannulated femorally, so they could walk and use their legs. And I wanted to talk about one patient in specific. I would like to talk about all three, but due to time, I just wanted to go through one patient and the sequence of events that led to the lung transplant. So patient one was a 16-year-old with cystic fibrosis. Over the 5 days since admission, they attempted to wean her off mechanical support, but each success off the ventilator was unsuccessful. So the healthcare professional team ultimately decided to cannulate the patient for ECMO. After a week of strength and reconditioning on ECMO, the patient was able to stand with assistance and walk around her bed. After 8 days on ECMO, the patient underwent transplant, and 24 hours the transplant, she was transitioned to trach collar and was participating in physical therapy postoperative day 2. She was ultimately discharged home 32 days after her lung transplant. So some key points from this article are that the use of ECMO in the rehabilitation process for patients is something that is difficult but possible. A big commitment from everyone in the team, including physicians, nurses, ECMO specialists, respiratory therapists, physical therapists, and perfusionists, is needed to help the patient improve while they're on ECMO. However, this commitment is needed for the patient as well, as they need to participate in the recovery process. Although ECMO can be used as a bridge to lung transplantation, this is not without complications. Some complications that I found in the research were blood clotting, vessel injury due to cannulation, and additionally, as I pointed out, survival is still better among non-bridge groups. Also, centers that are unfamiliar with ECMO or low volume centers report additional adverse outcomes. And there's also the idea that patients that are on ECMO for a longer time increase their mortality probability. So we have to get the patients that are on ECMO along in a timely fashion. There's one more additional complication that I like to point out specifically, and that is creating a bridge to nowhere. So because there's no destinational device therapy for respiratory failure, it's possible to create a bridge to nowhere. And I wanted to point out an example to illustrate this idea, and where a 25-year-old woman who was a lung transplant candidate was put on VA ECMO to maintain her transplant candidacy. However, while she was on ECMO, she developed renal failure, and this deactivated her from the transplant list. However, she was still awake and conversant, but she kind of had nowhere to go, and this put everyone in a difficult situation, the patient, family, and the healthcare professional team. I would like to point out the benefits of using ECMO as a possible bridge to lung transplant, and that patients on ECMO are more likely to receive a transplant due to the higher lung allocation score. You can also use ECMO with the addition of active rehabilitation and conditioning to improve post-operative outcomes. And as I mentioned earlier, with the use of ECMO, there has been a decrease in waiting list mortality. In conclusion, ECMO has been used as a support to help patients that are waiting to receive a lung transplantation. Although this is a viable option, it's not without complications, and it's essential to avoid a bridge to nowhere. As centers are becoming more familiar with ECMO, as we saw in the second study, the outcomes have become more favorable. And it's also important to note that with the use of ECMO, it's important that everyone assists in the rehabilitation process, and that the rehabilitation process is really what brings about the positive outcomes with the use of ECMO as a bridge to lung transplantation. Thank you, everyone. I would like to thank Perfusion.com for the opportunity to present, and specifically my professors Julie Collins and Jim Murray, as they helped me prepare for this presentation. Here are some of my references, and I would just like to open up to any questions.
Thank you very much, Brandon. Brandon, very nice presentation. As we've talked through this meeting here, there's a lot of literature that suggests that ECMO could be a viable option for bridge to transport in lung transplantation. So what could be done to improve the survival rate among our patients that are supported by ECMO prior to lung transplantation?
So I think a big thing, so as I discussed earlier, there was a high risk mortality rate early on post-operatively. And I think something that would be beneficial to this is assisting in the rehabilitation process, as I pointed out in the third article, with the use of physical therapy and attempting to strengthen the patient and not just let them sit there on the bed. This, I think, would be very beneficial in improving outcomes post-operatively.
Okay. Any other questions? In lieu of time, thank you very much, Brandon.
Yeah.
Our next speaker is from Phoenix, Arizona, who graduated from Arizona State University and is currently a first-year perfusion student at Midwestern University. He is heavily interested in trauma and would like to work at a level 1 trauma center in Miami or even New York City after graduation. He is currently wrapping up his first year and will be starting clinical rotations in June, where he will learn more about the field of perfusion. Please join with me in welcoming Cesar Delgado, speaking on validating effectiveness of the biocompatible circuit coatings by measuring biomarkers of platelet activation during cardiopulmonary bypass.
Awesome. Thank you very much for that kind introduction, Susan. I just want to thank everyone on my team, starting out Dr. Darbin, Caitlin, Miguel, and Amy for all their help throughout the experiment. And they're definitely they definitely play a huge role in making everything possible in terms of data analysis and running the experiments and coming up with ideas to make every experiment better. And so this is actually a pilot study that I'm excited to talk to you guys about. It's called Assessing Biocompatible Circuit Coatings Using Biomarkers for Platelet Activation During Cardiopulmonary Bypass. Perfect, but before we dive right in, I just want to give a little bit of a background exactly what we're getting into here. So as perfusionists know, one of our biggest concerns during cardiopulmonary bypass is activating is SIRS, which is the systemic inflammatory response syndrome, which can be detrimental for our patients. It can cause a variety of organ dysfunctions, and failure to attenuate this inflammatory response intraoperatively can result in renal injury, GI injury, myocardial dysfunction, coagulopathy, hemolysis, embolism, edema. As you can see, there's a lot of comorbidities that can be caused by the systemic inflammatory response during cardiopulmonary bypass. And if you look on the right, you can kind of see a little bit of indicators that would suggest SIRS. Some of them don't pertain to us specifically as perfusionists, such as the respiratory rate, since we're the ones that control the patient's respiration during cardiopulmonary bypass. However, there is some stuff that you would see in the ICU afterwards, and it can be very detrimental to our patient. In addition, the literature suggests that all patients experience some degree of SIRS during cardiopulmonary bypass. So no matter how healthy you are, or if you had no history of serious infection, cardiopulmonary bypass will lead to some degree of systemic inflammatory response. So that's a huge problem that us as perfusionists face during cardiopulmonary bypass. And then so if we get into the general mechanism of action, recent research suggests that activation of the vascular endothelium through cytokine-mediated events initiate SIRS. As we all know, this can be caused by neutrophil-related damage. So cytokines released by the vascular endothelium will call neutrophils over and basically cause a lot of damage whenever it's activated. So our aim during cardiopulmonary bypass would be to kind of attenuate this response so we don't get any neutrophil-related damages that can be detrimental to our kidneys and other organ dysfunction and cause other organ dysfunctions. The most common cause of these events are attributed to blood contact with foreign surfaces. As we know, we run, during cardiopulmonary bypass, we run the blood throughout the entire system, and our oxygenator has a huge surface area. So there's a lot of contact that the blood makes throughout our circuit, and it can cause a huge inflammatory response. And then foreign surface initiates simultaneous activation of extrinsic and intrinsic clotting cascade. Specifically, our circuit causes the intrinsic clotting cascade, and then the kinin system, which will eventually lead to vasodilation and can cause edema during cardiopulmonary bypass. The complement cascade, which is initiated by antibodies, and actually that will eventually lead to the neutrophil damage as it activates neutrophils. And then the fibrinolytic system. So that can be a huge issue postoperatively when we're worried about bleeding. And if you look on the right, you can kind of see a little bit of a summary regarding all the things that can be caused by blood surface interaction with our cardiopulmonary bypass. And definitely a lot of cytokine production, which can cause a lot of damage to our patient. Okay, and then here's two pictures basically of what I kind of wanted to look at regarding to platelets. So if you look on the left, you can see a picture of non-activated platelets, and then on the right, you can see activated platelets. Their structure is pretty different. You can see how the activated platelets have pseudopods, so that makes it a little bit easier for them to adhere to our tubing. And then the non-activated platelets are generally a little bit smaller, and they're circulating throughout the circuit, so you don't really see too much potential for adherence to the wall. And then, so when activated platelets, they change shape, develop pseudopods, express surface receptors, they aggregate, which can be a huge issue for us because they can cause strokes or embolisms. And then they release contents from their granules. And then also this activation could lead to a huge platelet decrease, which can eventually cause a need for transfusions after postoperatively. So it can also cause thrombocytopenia, and then it may require postoperative transfusions, which is bad. As we all know, we want to avoid transfusions as much as we can. It can cause trolley, which is bad for the lungs, allergic reactions, etc. Okay, and here's our platelet activation biomarkers. So for our specific experiment, it's a pilot study, so we're kind of just looking at right now, we're gonna be looking at hematocrit and platelet function, or platelet quantity, and then we're gonna be looking at the function a little bit when we start getting into TEG. But as you can see, there's tons of research out there on different ways we can assess platelet function. There's substances released from granules, specifically alpha and dense granules. Alpha granules are going to release more protein related biomarkers, and dense granules are going to release more chemical related ones, such as thromboxane A2 and serotonin. Those are vasoconstrictors, which would be bad for the patient. And then there's other common biomarkers such as P-selectin, there's histamine, and there's tons of other receptors that we're kind of researching a little bit more, so we can see how we can assess this platelet activation during cardiopulmonary bypass. Okay, and then for the prevention of cardiopulmonary bypass, or for platelet activation, the goal is to prevent the response or the formation of platelet aggregates during cardiopulmonary bypass. There's many ways that we can kind of prevent this activation. We can either modify our circuits, we can incorporate mini circuits due to the decreased surface area, or we can also add ultrafiltration during cardiopulmonary bypass. But the one that we're going to be discussing today is going to be biocompatible circuits. And there's also another option that we have. We can use drugs to try to attenuate this platelet activation. Okay, so biocompatible circuits. So they're designed to mimic the endothelium by repelling platelets and reducing the degree of inflammatory response. Common types of coatings include polyethylene oxide, polymethylhexyl acetate, otherwise known as PMEA. There's heparin coated circuit, as well as sulfate and sulfonate groups. Our specific experiment, we're going to be looking at two different circuit coatings, trillium by Medtronic, which contains covalently bonded heparin and sulfate/sulfonate groups. So there's different types of circuits out there in the market that use different methods for repelling these platelets, or just not letting them to adhere to the tubing wall. So the sulfate and sulfonate groups basically cause a negatively charged tube, much like our endothelium, which is going to repel the platelets and not let them adhere to the wall. And then heparin, that's another good way to prevent that adherence. And then for X-coated by Terumo, we're going to be using PMEA. That's also great. It's a polymer, so it basically causes an amphipathic wall, so the plates are not able to adhere as easy. Okay, so for our specific experiment, we used 15 liters of bovine blood. I basically would just pick it up at the slaughterhouse, and then I would insert 20,000 international units of heparin along the bucket. So I would try to attenuate the platelet activation as much as I can when we were harvesting it. And then we would use a CBC. We would run a CBC for it. So it would give us a ton of parameters such as platelets and hematocrit. And then I would dilute the blood as much as I could to achieve a hematocrit of 25%. This bovine blood would have a super high hematocrit, so there was definitely a lot of hemodilution that was going on. And if you look at that picture on the left, that's basically the concept circuit that we used. Basically, I would attach a filter to the bucket. I would attach a filter to the line that was inside the bucket, and then basically use counterclockwise direction to push it into a cylinder. And then once I had a certain amount that I wanted into the cylinder, I would take off that filter, grab that tubing, and then insert it into my reservoir. And then that would basically give me a way of measuring how much blood I wanted to add into the circuit. And then once I got the amount that I wanted inside the circuit, we would do the math to calculate how much crystalloid we would need to insert to achieve a hematocrit of 25. And then we would basically chase out the blood, and then that would give us our hematocrit. So that way we maintain some sort of consistency regarding all the samples. Okay, and then basically all of our experiments would be run. We would basically run the blood throughout our circuit regarding each circuit coding for 55 minutes, and then we would assess at 3 intervals. So we would do at 5 minutes, we would start warming to 37 degrees, and then once we got to 5 minutes, we would start cooling to 32 degrees, and then once we got to 30 minutes, we would start raising the temperature back up to 37 degrees Celsius. And then samples were collected for plasma after each interval and a complete blood count. And then at the 55 minutes, we would get a collection sample for TEG. So that would kind of give us information regarding platelet function and fibrin interaction at the end of our runs. And then we had 16 total runs, 11 with Trillium and 5 with X-coded. And that was just those numbers. There's no specific reason why we use that specific run number. It's basically the funding that we had, and we wanted to get as many runs as possible. So those are the type of circuits that we had at our disposal. Okay, and here's another view of our setup. That's a heater cooler you can see on the right, Soren 3T. As you can see, that's when we're cooling to 32 degrees, and then we would attach that to the left, that system on the left. As you can see, we had to salvage a ton of pieces. That centrifugal pump on the right, we had to grab it basically from another machine, and then we had to kind of like tape down a ton of tubing and stuff like that to like not make sure it doesn't move anywhere. And then we would just run it. We would run it for 55 minutes, and then we would collect samples at each interval. So that we would use that as biomarkers to assess platelet activation at each interval. And then we wanted to see if there was any trends throughout cardiopulmonary bypass. Okay, and then for our results, so as you can see on the box and whiskers plot on the right, at first glance, you can see that it appears as though X-coded shows a larger difference after 55 minutes. And then Trillium on the left shows a little bit more of a subtle difference once you get to 55 minutes. But if you look at the table on the right, it might also show, it also shows that a little bit. You would think, oh, well, there was a huge difference. This is in thousands. You would think, oh, this shows a huge difference with X-coded. So that means X-coded is a terrible circuit. But also we also have to take into account that there was a smaller sample size for X-coded, and our p-value would be more significant for Trillium. However, sample size does play a role, because the more samples you have, obviously, the more sensitivity you're going to have for your experiments. You're going to be able to measure those smaller changes. And one thing I personally found interesting is that if you look at Trillium from 30 to 55 minutes, you would see actually that the platelet number increased a little bit, which I thought was super interesting. That once we started rewarming, we saw an actual increase in platelets after it had already gone down a little bit. Who knows, maybe the aggregates disassembled and just came back into the circulation. But we do know that warming kind of did decrease the difference in platelets. Okay, and then that was within each coding. But if we look at between each coding, you would see the differences regarding time and the p-value as well. You would see also those same changes. for Trillium, for Trillium, the platelet number increased. For some reason, we want to look into that a little bit more in our next study. And then at 30 to 55 minutes for X-coated, it still decreased, but not as much as 5 to 30 minutes. And so if we look at the time interval platelet change, so from 5 to 30 minutes, you can see a drastic change in both circuit coatings in regarding to platelet number. You can see that there was a significant reduction in platelet quantity from 5 to 30 minutes and a much more subtle one from 30 to 55 minutes. And we thought that was really interesting, that you would see a huge decrease in platelet number at the beginning of surgery instead of at the end. So we're going to investigate that more in our future research. Okay, and then we also took a look at hematocrit just to kind of see if our circuit was just destroying everything, all of our blood components in general, or was it just looking at destroying platelets? And then we also know that hematocrit does play a role in platelet activation as it causes marginalization to the tubing wall. And as you can see, the hematocrit difference within each coating and the mean standard deviation. So from 5 to 30 minutes, you saw a percentage difference of 1.52%. That means our hematocrit decreased from 5 minutes to 30 minutes. And then on X-coated, it also did by 1.10. As you can see, there was a bigger change in Trillium, but again, that might be due to the sample size that we saw. However, we did see for X-coated, there was a much larger p-value, which would also indicate just sample size errors. Okay, and then the hematocrit difference between each coating and mean standard deviation, we kind of see those same changes. Hematocrit also did decrease throughout surgery, but I think to a much lesser degree than platelets did. Okay, and then here's where it kind of gets a little bit interesting. So we actually used a tag. We used platelet mapping using a tag 6S. And basically after speaking to the hemanetics consultant, she recommends that that we use the tag 5000, but we use the tag 6S because we also heard that ECMO centers use that all around. So we definitely wanted to look at, so she told us for specifically for platelet mapping to look at the HKH value instead of the ACT-F and the ACT-ADP, just because we're not sure if that correlates with what we were looking for a little bit more, and it's not typically used during cardiopulmonary bypass. So she suggested just like an HKH, and we did see some interesting trends as well. So if you look at baseline X-coded, the maximum amplitude, which on TAG, that means that it's the strength of clot formation. So it'll get us kind of some indicators of platelet function and platelet fibrin interaction and the clot strength in general. For X-coded, our initial samples was over 71, and that's millimeters. And then for baseline Trillium, it was at 70 millimeters. So as you can tell, pretty strong clots. And then after 55 minutes through running it through the circuit, we wanted to assess that clot strength again. So we looked at HKH for X-coded, and it went down to 69.7 from over 71. And then for Trillium, it went down to 67.28. So we're starting to see that cardiopulmonary bypass may actually decrease platelet function and interaction with fibrin after you're running it through the circuit, which is kind of what we expected. And then so we did run it on, so we can trust these p-values a little bit more because we did have the same sample size for both of them. And it shows a significant p-value for both of them. So that was something that we were definitely excited about, that we get to see that cardiopulmonary bypass does decrease platelet function as well. And then so basically, if we're looking at the entire data and bringing it together, Trillium did show statistically significant difference in platelet count. Larger sample size may have played a role. So that's what I was talking about a little bit with the p-values. It might have manipulated them just a little bit. However, in both circuit coatings, there was a total decrease in both platelet quantity and hematocrit. And we saw that huge difference more in the 5 to 30 minutes than in the 30 to 55 minutes. And we're still kind of investigating why that is, but we do know that we saw a huge decrease in blood components at the beginning. It might be due to the cooling section of it, or maybe I was moving around the samples a little bit too much, but we did see a huge trend on that. And then TEG showed a statistically significant decrease in HKH in both circuits. So we do know that platelet function did decrease at the end of our experiments. And then so overall, when we looked at all the data and kind of bring it to more relevant to us, so we were unable to confirm optimal biocompatible circuit. That's just because we were unable to compare that to a control group because we were honestly not able to find any sort of uncoded circuits. It seems that most of the companies are kind of just focusing on coded circuits, and it's hard to get a hold of it. So we weren't able to compare it to a control. So we were kind of just looking at them and them together. And the literature does show that circuit codings do play a huge role. So that's not the question that we were trying to answer with that. And then we did see that platelet decrease is a result from cardiopulmonary bypass, as suggested by our extrinsic biomarkers, such as platelet quantity and platelet function that we found through TEG. Intrinsic biomarkers may give more information regarding activation. So at the end of our samples, at the end of the sample collection, plasma sample collections that we would do after every interval, we actually collected those samples. They're in the freezer right now. And we want to measure biomarkers such as platelet factor 4 and beta thromboglobulin. So we're going to be adding that in our next study. This is a pilot study, so we're going to expand it a little bit more after that, after we do more samples and stuff like that. But we do still have those plasma samples, and we're going to see the intrinsic activity of the platelets later on. And then so potential factors of platelet reduction could be the temperature. So I did cool the temp. That's why we kind of cooled the temperature a little bit and then brought it back up. So maybe that played a role. We did see that there was a huge decrease in platelet number when we were decreasing the temperature. Maybe the time of bypass has some sort of influence. At the very beginning, we did see a huge decrease in everything. So maybe the acute response to the tubing and stuff like that caused that huge difference. And then maybe the blood components just kind of got used to the circuit and stopped activating after that. And then our shear stresses. So we do know that hematocrits cause higher RBCs in the blood. So the more RBCs that we have, the more they kind of cause shear stresses with the platelets and push it towards to the wall and cause more platelet activation. And then drawing samples as well. So I tried as hard as I can when I was doing the samples to not push air into the circuit, because I know that would cause hemolysis. But perhaps when I was drawing those early samples and moving stuff around, maybe that had a huge impact in the platelet reduction seen at the beginning. And clearly hematocrit we were looking at too. The higher the hematocrit we saw as well, the bigger difference in platelet reduction that we saw. And then for future suggestions, so we used the TEG 6S, which uses resonance frequency. So that's not typically advised for the purposes of bypass. However, speaking to the hemonetics consultant, she said that the HKH value was something that we could look at, but she suggests for our next experiments to use a TEG 5000, which uses a torsion with a pin. So basically, you're going to spin a whole blood sample, and then you're going to see the fibrin formation off that. So that'll give us a little bit more information regarding our R value and stuff like that. And maybe we can start bringing in other coagulation factors into the mix and not just look at platelets. And then I would also suggest one of our biggest things would be to include larger sample sizes. That's just due to the impact that it had on p-value. As we know that the higher the sample size, the more significant p-value we'll get. So we kind of hope to run more larger sample sizes, so we can also increase the sensitivity of our test, and we can see those smaller changes between each experiment. Okay, and here are my references. Okay, and then that being said, I'll open up the panel to any questions if there's any.
Very good presentation. It was very nice. Thank you very much. That was very scientific, very good. Got one question. You basically were showing that you saw your platelet counts increase when you went to the rewarming phase. And that's true, because the platelets aggregate when you're at cooler phases. They basically clump together. And therefore, you're going to see that with any circuit at that point in time, where as you rewarm, and even with, and again, I agree with you, the TEG 6 is not a way to go to measure that. You definitely need to go with a TEG 5000. Mm-hmm. So, I think you're going to show a different result in the future when you use the TEG 5000 for your study and the following study of this group. So my advice would be, but you're definitely going to see platelets. Increase in platelet count. When I did the studies with platelets and TEG, we always saw that as you rewarm. But excellent presentation.
Oh, thank you. Yeah, we found that super interesting as well. We're gonna investigate that a little bit further in our future experiments.
I think that's pretty much all we have time for, right, Susan?
I think so, yes. Thank you so very much. These are great.
All three of y'all did really well.
Very good. Yeah. Hands to you guys. Very good. And then next, Brian's going to put the voting
Website up.
If you want to stop sharing your slides, and then Brian will put the link up for voting. This is going to be tough, you guys.
All right, it's coming right now. Hang on.
While Brian's getting to that, I have to say, Caesar, a healthy research and a healthy presentation, Brandon and Madeline, is to be your own critic. So I appreciate all the explanations of where your research might have been faulty there. You kind of de-iced everything from people asking questions, but it's just the way we do research, man. It's tough, and you gotta look at all those faults when making a valid point. And I do love to see that if you go ahead and find uncoated circuits, or also include phosphochloric, the other circuit, phosphochloric, whatever it's called, add that to the make as well. Interestingly, when we did some studies with ECMO circuits that was way back, we saw the complement activation in the first couple of hours, but then after first couple hours, I don't know if it endothelialized the uncoated tubing at that time or not, but it would even itself out. So that's something to think about, when you say the dramatic increases were in that first short period of time rather than later in the study. So something to think about as you further your research on this.
Thank you.
You guys are all winners in my book.
Maybe we can just announce it. It's like when I share
Sure.
Okay, well, go slowly on it, Brian.
All right, let's try this one more time. Can you see it now?
No.
Yes?
Yes.
There we go.
Okay. All right.
That's our voting link. You can go in there and rate these presentations.
So do we give the winners now or later, or how do we do that?
We will do it in a little bit.
Oh, just a little while.
And again, for our audience out there, Brian did answer that all the recordings from the Sanibel meeting can be found afterward on the Sanibel Symposium YouTube site. So you'll find them by the day, and you'll find individual recordings as well. So you don't have to pan through all the days. So, and that's to anybody that signs on to that, not just registrants. Also, I might develop a GoFundMe for my next hat if anyone wants to go ahead and donate. That would be wonderful.
No, I really don't.
That's a personal choice, man. It's subjective.
Da, 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 da. A lot of votes coming in, Brian.
Yep.
Okay.
Why?
Were all your classmates and all your friends logged on and voting?
Hopefully.
Yeah. Brothers and sisters and parents, grandparents.
Give it just a couple more minutes here.
So Rabia, it is in the chat box link if you want to go back a little further up. She's asking for the link.
It's also right on the screen.
Yeah, but I can't push that.
That's true.
Are you guys as nervous as we are? But just remember, all you guys are winners, though. You know that.
Absolutely, they're all winners.
Yeah.
Susan, I think we have the results.
There are 600 people registered for our meeting. Can you believe that? It's pretty neat, with about 350 logged in every day. So great successful meeting, I would think. Yeah. Hopefully we'll be live next year. We usually have our students come and they work in our booth and help us with the registrations and and everything. But unfortunately, since we're not live, we can't do that, darn it. But so we are always would be able to get to know our students and very personal and have a lot of fun with them. So, oh, look at your little doggy.
Yes, she also likes Florida. So hopefully next year we'll be in Florida.
Yeah. It's a Dalmatian or?
Yes. Yep.
Yeah. Fun dogs.
She loves to make Zoom appearances.
Oh, yeah.
Hey, Susan, I think we got it now.
Yeah, but
All right. 1 second.
okay. Do we have the ready to announce them? Wow, this is really close. Good job, you guys, every one of you. So we're going to go we'll announce the third place first, then second, then first. And once again, this is the Ken Farmer Scholarship, and it's awarded to a perfusion student who composes and presents an outstanding presentation for this Sanibel Symposium. And the scholarship is awarded in amounts of $1,500 for the first place, $1,000 for the second, and $500 for the third. So I'm going to announce the winners now. Drum roll, please. So on the third place, once again, you guys were all very, very close according to these numbers here. First place is Madeline from Quinnipiac University. Congratulations, you're the third place winner with $500 scholarship. Congratulations, Madeline.
Thank you so much, Susan, and everybody from Sanibel. Hopefully we can see you all in person next year.
Yeah, job well done. Job well done.
Thank you.
In our second place, with $1,000 scholarship, goes to Brandon Gertz with Rush University. Congratulations, Brandon. Job well done.
Thank you. Thank you.
And so our grand prize winner this time, for first place winner with $1,500 scholarship, is to Cesar Delgado from Midwestern University. Congratulations, Cesar.
Thank you very much, everyone. We're glad and I had a great time doing this.
Good, good. We enjoyed every one of your presentations, and you guys are all very, very close, and we loved your participation. Thanks again.
Yeah, keep up your research and put an abstract in for next year. Come live, hopefully come live.
Yeah. Yeah.
Thank
very
you
much
again.
so. Thank you, guys.
Have a great time.
Job well done.
Stay in touch. Thank you.
Thank you.
So this concludes our symposium, Sanibel Symposium for the 10th year, and hopefully next year we'll be live. So see y'all then. Thank you all.
Thank you, everyone.
Bye-bye.